challenge, we have interprofessional debates. We also have outreach camps in the malls. So health profession students educating the public about various topics in relation to interprofessional education. We were invited to share our experience of student leadership in this book about interprofessional education and collaborative practice. So I wrote this chapter with the two presidents from the IPE Student Association. And of course, research was something very important that we took care from early on. And it really made sure our programs was successful because it was based on the evidence and what we were hearing from the various stakeholders. And I wanted to share this. So Jawahir, the lady who's wearing the abaya, is a medical student. And she was the president for IPE, now currently a resident, graduated. And Kauthar was a vice president, and she was a pharmacy student. So they worked together through extracurricular activities. And they posted this, and I was just so happy to see them. They've been working together through the curricula, through extracurricular, and now they're working together in the practice. And they posted it on Instagram. I retweeted it. Then I had one of our alumni. She sent a message saying, honestly, doctor, it's very different when we are working with the new doctors who are graduating from College of Medicine. They actually understand and appreciate our roles and sometimes seek us even when we aren't part of their team. We don't have to explain our role every time. So I felt this was really a beautiful encounter. So lessons learned from Qatar journey was really structure matters. So having that dedicated IPE committee was key. Evidence-driven practice was also very important. The faculty development, it's absolutely crucial. Global engagement and student empowerment. And IPE has been growing in the region from early 2010 in various universities in the region. And that's why we felt there was really a need for a unified interprofessional collaboration in the Arab region. So we began as an emerging network, part of interprofessional.global in 2018. In 2023, we moved from being an emerging network to a fully established network in interprofessional.global. And currently, we have more than 200 members within our directory. This was the first regional meeting. It was a virtual meeting, and some of the colleagues are with us today. This was the first meeting where we started really talking about having a network within our region. Then Qatar University submitted a bid to host the 11th edition of the Altogether Better Health, which was hosted in various countries, starting from London in 1997, Canada, back to London, Sweden, Sydney, Japan, USA, UK, New Zealand. So we submitted the bid to host it, and we were announced to be the host in 2018, to host it in 2020. But then nobody knew about COVID, so it was postponed until 2023, and that was also after the World Cup that happened in Qatar. So we hosted the 11th edition of the Altogether Better Health under the theme Cultivating a Collaborative Culture, Sharing Pearls of Wisdom, and I know some of you in this auditorium have attended this conference. We had Her Highness Sheikha Moza, the President of Qatar University and the Minister of Health. And the two significant launches from this was the formal establishment of the Arab Network for Interprofessional Collaboration, and also we had the Interprofessional.global Winter Tour Doha Declaration. So what we are aiming to achieve, our vision in ANIC was to transform health and social care systems through interprofessional education and collaboration for optimizing patient care to improve outcomes and promoting well-being for the individuals. This was the first partnership meeting that we had in ANIC in 2023. And now this is the second one in Abha. And this is a picture from yesterday. We had our second partnership meeting with colleagues from the region. And also I wanted to share some research that was done led by my colleague, Professor Susan Waller, looking on interprofessional education in health profession education programs in the Arab world. So this is a scoping review protocol that's now under review. And so within the studies, it mapped the status of pre-licensure health programs focusing on the context, the process, and the product. And what we have identified in this study, that there is limited faculty development, cultural sensitivity, and emerging frameworks. There has been the emerging frameworks from Qatar, Lebanon as well. Process was predominantly case-based and simulation-based learning with few structured summative assessment, and the product was mostly reported at level 1, reaction attitude with minimal evidence of behavior. And really there has been lack of standardized regional frameworks and summative assessment.
2 minutes, Doctora.
Yes, I'm finishing, yes. So the horizon, a shared Arab action agenda. So the regional scan highlighted the need for teamwork and communication to have the IPE within our context, and that is culturally adaptable. The need for early and longitudinal IPE exposure and robust evaluation mechanism. Now we have 3 main working groups within ANIC, one focusing on research collaboration and impact, capacity building for faculty and institution, and lastly, we are really working on trying to strengthen our communication and engagement pathway. So today, you choose the base. If you are not the light, be the spark. Ignite the conversation. Unite the team. Put the patient first, always. From Doha to Abha to Kuwait and every Arab city, your spark and our spark equals a region lit by collaboration. We don't wait for a brighter future. We build it now, together. اليوم أنتم من يحدد الوتيرة. إن لم تكن أنت الضوء فكن الشرارة. أشعل الحوار. وحد الفريق. واجعل المريض أولاً دائماً. من الدوحة إلى أبها إلى الكويت وكل مدينة عربية. شرارتك مع شرارتنا تساوي منطقة يضيئها التعاون. نحن لا ننتظر مستقبلاً أكثر إشراق بل نبنيه الآن معاً.
Thank you, Dr. Ala, for this nice and fantastic journey that you presented. I'm sure we'll have some comments and questions, but we'll leave it at the end, okay? Let's now call our next speaker, the third speaker, Professor John Gilbert from Canada. Professor Gilbert, he's Professor Emeritus at British Columbia, Vancouver, Canada. And he has a lot of contribution to medical education, and especially in interprofessional education and collaborative practice. Additionally, he received the Canada award. It's the order. It's the highest country's civilian award for his health care and contribution. So please join me to welcome Professor Gilbert.
Well, good morning, and thank you to the organizing committee for inviting me to join you today in this very, very exciting meeting. It's hard for me to think back to 1963, when the Dean of Medicine at the University of British Columbia, my university, wrote a paper in which he used the word interprofessional for the first time. And his vision was for all health and human care professionals to learn together in the same environments and to work together in the same environments, all together on the same patients. Now, in this presentation, I'm going to cover trends in educational innovation, challenges in organizational structure, and then strategies for curriculum development, all within the context of interprofessional education for collaborative practice and care, recognizing that I have sundry colleagues at this meeting who will not be hearing this for the first time, and some of you will be hearing this for the first time. So let me say, first of all, which one do I press? Ah. Sorry. I've done in by the... That's not mine. Sorry, those are not my slides.
We need one of the technicians to help.
Sure, those aren't my slides. Which one goes forward? No, I'm here. Which one goes forward? This one? Oh, let's see. Aha. Magic. Right. So after that brief introduction for technological innovation, let me continue. So I want to say a word, first of all, about trends, and I would like to thank Drs. Ali and Ala for just two wonderful presentations. They cover virtually anything that I could ever think about, but I'm going to try to talk about some of the issues that both of them have and will encounter as they roll out their programs. So, in retrospect, the COVID-19 pandemic significantly impacted professional education and practice, and I think it served as a catalyst for innovation and transformation. And COVID, I think, highlighted the critical importance of interprofessional collaboration. So you think about how much job sharing and job shifting we did during that time. And so COVID presented unique opportunities for sustaining the development of IPE. So what did we learn? Well, we learned that educational and practice institutions should focus on implementing educational integration. So first of all, emphasize team-based learning approaches that were clear about the clarity of the patient's voice. And then second, we learned to use a variety of learning models, including didactic and hybrid programs, community-based programs, and highly significantly, and I think very exciting, a variety of interprofessional simulations. And third, I think we learned that through the integration of virtual and technology-enhanced learning, we entered a new and changing world of hybrid learning, which I still find very challenging, my university finds challenging, and I'm sure you do. So then, let me say a word about educational integration. What are the trends in educational integration? Well, first, there's a growing emphasis on leveraging digital technologies and virtual learning environments in IPE to meet IPE global systemic goals, which are really extemporized in interprofessional.global and then interprofessionalresearch.global. I think secondly, there's a growing emphasis on the patient voice within IPE initiatives in my country, and when research is approved by our federal government, there has to be a patient on every research grant. The patient has to stay with the grant right the way through to publication. Because the idea is reinforcing patient-centered care as a core value prior to professional registration, and then, of course, practice. And third, we see the innovative IPE curricula that are increasingly incorporating experiential learning. I never thought I'd live to see this, but it's very interesting now how we're turning to look at experiential learning opportunities like structured ward and clinic-based interprofessional work and a larger involvement in post-discharge planning and care, for example, through home visits. We've been experimenting with this. It seems to be pretty effective in terms of interprofessional learning. And we see virtual interprofessional VIPE, VIPE, which has shown significant benefits in development of IPE competencies when it's compared to traditional in-person learning and training. So let's take a quick look at competency development. It's now clearly recognized that interprofessional competencies need to be continuously developed throughout the learning process, prior to entry to practice, and then in professional practice. These are not things one simply does in education. And this recognition led to the regular updating of competency frameworks. Dr. Alla mentioned the American one. I'm very proud about our Canadian Interprofessional Health Collaboratives competency framework because we call it Advancing Collaboration. We refreshed it last year, and it really is not a checklist. You need to take a look at it. And many health and social care professions are actually adopting competency-based frameworks as part of their curricula design which I find very exciting, that really does explicitly incorporate IPE and collaborative practice. And so I've said the networks, interprofessional.global, interprofessionalresearch.global, are promoting evidence-informed policies and practices in IPE through their global collaboration and research across that entire federation that Dr. Alla put up to show you. And I think this trend towards global cooperation is fostering exchange of ideas and best practices across many countries that focus on the definition, which Dr. Alla put up, and competency frameworks. We're finally recognizing the power of that CAPE definition and the power of competency frameworks in moving IPE forward. So what about some of the challenges? Well, it was very clear and continues to be very clear that strong institutional support first of all requires establishing dedicated organizational bodies and advisory boards, as so clearly demonstrated by Dr. Ali and Dr. Alla, and particularly in health and social care professional associations, not at only the educational institution, but in those associations themselves, and equally, if not more important, in accrediting agencies for educational programs, because it's those boards and those advisory committees that will ultimately be charged with developing clear standards for building IPE on competency frameworks. Second challenge, securing sustainable funding and dedicated infrastructure. These are hugely, hugely important. I would jokingly tell audiences that IPE cannot be done on a Friday afternoon in Vancouver when it's raining and we have an hour free between 1 o'clock and 2 o'clock, and by the way, here's $15 to buy Coke. You have to have sustainable funding, you have to have dedicated infrastructure. They are hugely, hugely important if IPE is to be sustained and continually and continuously developed. And third, it's vital that centralized support is created for interprofessional activities, for evaluation of programs, for longitudinal research, longitudinal evaluation, because they are critical if we're to better understand the downstream effects of building IPE. If you don't do the evaluation, how can you say that you're doing much good anyway? So what about structural barriers? Well, across my almost 60 years of being engaged in this interprofessional education work, it's globally known now that there are, right, Dr. Alla, right, Dr. Ali, structural barriers to IPE in the form of resource constraints. And the list of barriers is extensive, believe me. I wrote a chapter about this in 2015 and we're still dealing with some of them. But they include poor and insufficient funding, limited infrastructure for IP activities. I always love to look at Dr. Alla's materials online because I can see a great deal of this infrastructure working, and it's fantastic. Inadequate time in the curricula, and that's a topic that will be talked about a lot at this meeting. And then just the rigidity of curricula that seem to be entirely uniprofessional. It's a giant mountain over which to climb, and again, Dr. Alla, Dr. Ali have shown ways of getting over this mountain. And then, of course, as Dr. Alla has mentioned, inadequate faculty preparation for IP. Wherever you go in the world, believe me, you see these structural barriers. And then, of course, there are always problems with professional dynamics in IP teams. Think about hierarchical professional attitudes. They don't exist. They do exist. a poor understanding of non-regulated members of the health and social care teams and of affiliated occupations. So you don't know what a lab technician does? Power imbalances among the members of the IP team. How are we addressing that? How will we address it? And though I hate to say it, professional competition and turf protection within so-called teams. What about educational barriers? And I think that Dr. Ali and Dr. Ala and many of you here have experienced what some of these are. First of all, there really is a truly significant disconnection between campus-based learning and practice realities. And I just want you to think about that because I'm not going to go much further. What are those disconnections between all those wonderful things we think we're doing on campus and then what is the practice reality? And these disconnections then create conceptual barriers, which then impede, of course, implementation. Second, there's the matter of when best to introduce IPE, and I'm always, again, delighted when I look at Dr. Ala's website to see how she's managed to climb over this particular barrier. Introducing IPE is a topic that remains really debatable, and we're still grappling with the thorny issue of when students have developed enough professional identity to meaningfully contribute to interprofessional learning and practice. Think about it. Is it the first year? Is it the third year? Is it the fifth year? Which program are you talking about? And then third, in practice settings, there are a number of questions about clinical learning that impact effective interprofessional practice. How do you maximize interprofessional time for direct patient care? How to interprofessionally understand a patient in the context of these social determinants of health. That famous line, it's much more important to know what patient has a disease than what the disease is that a patient has. How to build in time for practitioners to reflect interprofessionally on their practice and in their practice. And then how to develop effective interprofessional communication between team members, which we know is a gigantic problem. Let me turn to professional barriers. So professional barriers can be seen first in both cultural and system issues. Gender segregation in some regions, limited culture of collaboration within health and social care systems. Think about that one. Financial implications of system change. Oh, you can't possibly do that, that'll be half my budget. Regulatory and legislative barriers. That's not in our accreditation. The law doesn't say you can do that. And then second, of course, as Dr. Ala said, faculty development. Always and forever a professional problem that is a very big barrier. And we know that there's an ongoing challenge in preparing academic and clinical staff for interprofessional facilitation because many educators in both environments, both on the campus and in practice, are really just poorly prepared for interprofessional facilitation if they're prepared at all. Sometimes they're told, you're going to do it, and that's all there is to it. And who's going to prepare them? And we know that IPE requires specific training programs where academics and clinical practice educators must themselves engage in interprofessional learning in order that they learn to think and to be truly interprofessional. Let me then turn to strategies. The historian F.W. Maitland observed, we should always be aware that what now lies in the past once lay in the future, a pertinent observation on the current status of IPE. But we know that in order for IPE to be implemented in new settings, we've heard about it this morning, and sustained once they're established, there has to be, as I earlier observed, committed investment in organizational reconfiguration, such as comprehensive interprofessional preceptor and mentor training programs that really focus on learning and understanding the definition of IPE, thank you, Dr. Alla, and the fundamental importance of interprofessional competency frameworks. Thank you both to Dr. Alla and Dr. Ali. Second, a clear and unambiguous financial support for ongoing professional development in collaborative practice, where financial support is embedded as a line item in the budget of the institution and not something that goes in one year and is taken out the next. And it's not something that says, here's $10 to do it on a Friday afternoon because it's raining in Vancouver. And then institutional awareness. How do we raise institutional awareness? Well, we know that institutional leadership is crucial in addressing challenges to IPE, such as professional stereotypes, role blurring, and of course, communication issues, because each of them and many others hinder interprofessional collaboration. So what are the specific leadership approaches and strategies that can successfully navigate these challenges and foster and build a collaborative culture among many different health and social care professionals? At my university, we have 15 different programs. Statistics Canada has 85 different health occupations. Think about it. First,
Dr.
focus
John,
on the role
Dr.
of
John,
leaders
2
in
minutes.
creating learning environments. It's so good to hear Drs. Alla and Ali talking about this morning. Creating learning environments and practice settings that promote the acquisition of interprofessional competencies. And this means exploring
2 minutes.
and implementing effective leadership development strategies across all levels of an organization. It's not just one level where you want leaders. It has to be across all the levels. And then secondly, the role of institutional policies in creating supportive leadership for IP. It's fundamental, it's critical. The importance of leadership support and administrative backing for successful implementation of IPE can't be too highly emphasized, and it's so wonderful to hear about what Drs. Alla and Ali are doing around this. Then curriculum challenges. Now, we could talk forever about curriculum challenges. So the curricular bridge between education and practice is something that we think about and think about and think about until we think we can't think about this anymore, but we have to keep thinking about it. Linking theoretical learning with clinical learning practice experiences. Identifying and using model units within practice settings that demonstrate excellent collaborative practice. Think about diabetic care, COPD, rehabilitation, great units in which to practice interprofessionally. Ensuring that it's clearly embedded in the curriculum of the practice environment. I'm not talking about the campus. How do you put a clinical curriculum in place in the practice environment? Be sure that IPE integration is clearly embedded then in the curricula of those rotations as they occur with our students. Developing, implementing interprofessional simulation-based training. As I said, I find this a really exciting development. I think it's going to go a lot further. And then aligning interprofessional curricular objectives across the accrediting bodies. There's no point in having one professional association saying, oh, well, we're putting interprofessional education in our accreditation if 8 other accrediting bodies say, well, what do we want to do that for? We've done it with 12 bodies in Canada, but we're still working on trying to make it work properly. coordinating calendars, coordinating curricula across the programs, sharing physical space. I do not want to go to one more educational institution that says, oh, can we show you our simulation lab? Only it's 10 people telling me, oh, I would like to show you our simulation lab. Heaven forfend. Coordination of physical space and technology. And then, of course, between each and every one of us, developing a shared competency framework about interprofessional education. We've got to do that. And then finally, almost, practice or clinical education. I prefer to call it practice education. Some of my colleagues in social work are not happy with clinical. First, partnership development. We've heard about partnership developments, establishing those with health and social care facilities in the community, but also including NGOs. We've been working with some of our NGOs in Vancouver. It's amazing how much different their population is than the one we imagined, fostering relationships between educational and research institutions. Dr. Alla put up some wonderful papers that have been published here, and we know, Dr. Alla and I know, and everybody else knows here, that we have to build this relationship between educational institutions, research institutions, and then build research networks so that I know what's happening here, I know what's happening. I say, oh, I think we could do that. Let's think about a longitudinal study together. And then secondly, active inclusion of IPE in setting quality improvement goals. For example, measuring patient outcomes and satisfaction after interprofessional team care. We do a lot of QI measures at the moment, but nobody has yet, as far as I know, looked at a team that has been truly interprofessional. Evaluating operational efficiencies as effects of IP practice. Assessing the satisfaction level of those who are working interprofessionally. I have never seen a satisfaction study, by the way. I'd like to see one. And again, by benchmarking one IPE practice against another IP practice, to see what is the balance and what is it that we're missing. But there are two fundamental questions related to these strategies. First,
2 minutes, Prof. Gilbert.
Policy frameworks, what policy frameworks need to be developed in order to build these two strategies? And second, how can policies be developed to ensure that all relevant health and social care professions and occupations working in a practice setting are included in meaningful discussions about IPE initiatives? I don't like to say it, but that's been a big hole in my country, and we're trying to work on it. So, joining the dots. You know, academics and practitioners who've been working for more than 60 years on trying to effect system change see very clearly that successful implementation of IPE-CP really does require understanding, addressing, and then leveraging these global trends, the challenges, and the strategies of which I've been speaking. Successfully creating effective, sustainable, and sustained collaborative interprofessional education and practice environments still has a very long way to go. Thank you for your attention. All my relations.
Would you join us, Prof. Gilbert? Dr. Ali? Dr. Ali,
Here.
Dr. Ala.
Dr. Gilbert, come. Stay with us, please, here.
We have 5 to 10 minutes for questions and probably some short comments. Prof. Zahir, can you give the microphone to Dr. Zahir? Do you have microphones? Dr. Zahir in the front. It seems that technicians should be part of our interprofessional collaboration.
Bismillah ar-Rahman ar-Rahim. I would like to agree with every word I heard from Professor Gilbert and Dr. Ala, with one exception. May I? Repeatedly, Dr. Gilbert, you refer to the patient care. The same thing with Dr. Ala, patient care. With all the progress which you are making in interprofessional education and training, which I appreciate it highly, I would like to say one day that we also tackle this problem. Instead of saying patient first, I hope that we would say people first. You both agree with me. You see, so this is only thing which I differ a little bit from you. Otherwise, that's great. Now I would like to change to Arabic language, simply to emphasize that the Arabic language is capable of conveying the medical messages, as the French and German, Russian, Chinese, and Finnish and Swedish, and it is capable. So allow me, please. Probably Dr. Ali will translate to you. الحقيقة مع هذا التقدم اللي أنا جدا سعيد إن أنا أسمع والستراجل، يعني ما هو شيء سهل تحول التعليم الطبي إلى الانتر بروفيشنال، لأنه في تحديات كثيرة جدا حتقابلكم. أتمنى إلى جانب هذا في 4 أشياء لابد نعنى بها في التعليم الطبي كتحديات يجب أن نقابلها. أول شيء التعليم الرقمي، وأنا سعيد أن أنا أشوف هذا التصوير، لأنه هذا ممكن يوصل الكلمة إلى كل أنحاء العالم. فلماذا لا نعنى بالتعليم الرقمي لكل مناهج التعليم الطبي؟ وهذه في يدنا إن شاء الله، وهذا هو المستقبل. الشيء الثاني التعليم التفاعلي، وأنا أعرف أنه بذرة التعليم التفاعلي وجدت وموجودة وبيهتم بها التعليم الطبي. على ذي الأخوة الكرام، أتمنى أشوف المزيد من التعليم التفاعلي اللي الطالب يروح يدرس ويبحث ويتعلم، يسهل له العملية، والوقت اللي يمضي فيه مع الأستاذ أو المعلم للنقاش والحوار. ماذا؟ لماذا؟ كيف؟ أنا ما أوافق، أنا أوافق. هذا هو النوع من التعليم الذي نريده. الشيء الثالث اللغة العربية. اللغة العربية ليس رفضاً للغات الأجنبية، يجب على كل ممارس أن يجيد لغة أجنبية، يجب حتماً، وإلا ما يأخذ شهادته. لكن اللغة العربية قادرة، وخاصة إذا كان التوجه المستقبلي للتعليم هو الحوار. بس، وشكراً والسلام عليكم.
شكراً جزيلاً دكتور. الحقيقة الوقت يداهمنا، فلهذا أنا حريص حقيقة أيضاً على جدول الزملاء، وأعرف اللجنة المنظمة شوية دقيقة، فناخذ سؤالين. تفضل دكتور، تفضل.
السلام عليكم ورحمة الله وبركاته. Thank you for all the speaker for this inspiring talk. For Dr. Ali, I really love the governance of the interprofessional education, but I would suggest to pay attention for 2 things. The first one is the rules and regulation that entail this change, and the second, thinking of the incentive scheme for driving the implementation and sustaining also the implementation. I don't know what is your thought about that one. And I have another question for Dr. Ala for what she did. We know that the health determinant of yeah, the determinant of health in the medical sector, we're talking about 20% modifiable reasons. What about the others? I mean, what was your experience in including the other health influencers, like the social care, psychological care, within the training, and what was the impact of that? Thank you.
شكرا دكتور خالد. دكتور علي, would like to respond?
Thank you, Dr. Khalid, for your comment. I agree totally with you. There is dramatic changes in the اللي هي الحوكمة, على أساس البروف زهير يعني يسعد بهذا التعريب. فعلا الحوكمة الآن هي يعني شيء في غاية في الأهمية. وطبعا there is also a lot of changes اللي هي في ريادة الجامعات وأيضا مزايا الكليات. فأنا I'm expecting a lot of changes going in the same line with the 2030 vision.
شكرا دكتور علي. دكتور آلاء.
شكرا كثير. Thank you so much for your question. يعني for sure when we are doing any kind of activities, we want to try to cover it comprehensively. So usually the first like here, which is at the exposure level, we are open. So the topics are not clinically based. We're looking into things, for example, mental health, looking at the social aspect of mental health. Smoking cessation, that's also another topic. Looking onto motivational interviewing. The public health aspect is also very important. So trying to incorporate a lot of these are really key. So that's why usually within the exposure level, these are the kind of things we're looking at, including also patient safety and quality, how to be an effective member of the healthcare team. Before moving into the clinical aspect, so they need to understand their roles and responsibility. They need to understand their contribution to the healthcare team, know how to communicate with each other before actually dealing with clinical cases.
شكرا جزيلا. أعتقد الوقت حقيقة يداهمنا.
Before, Prof, if you allow me, maybe you'll take this opportunity to ask Professor Shihri about his opinion about IPE, please. If you allow.
Actually, I'm here really to listen to the experts about this issue. But if you ask me about my opinion, I agree with many of the issues that were said. But I think there are two important issues that we should always think of. First, keep interprofessional education in the region a part of the activities of medical education. Don't separate them if you can, because really, I think there is a synergistic effect between the two activities. Number two, I think it is important to concentrate on hands-on experience, and if we really concentrate on giving our students enough exposure in hospitals and health professions, institutions, that is important in every aspect that will lead to success in any initiative that we want. Number three, I think staff development is the way forward. Thank you very much.
Thank you very much. Thank you very much.
I think we conclude.
Yes.
I would like to thank, with your name, Dr. Gilbert, Dr. Ali, Dr. Ala, and also my co-chairman, Dr. Abdelaziz.
Thank you very much.
And I'm sure you will have more chances to discuss further issues in the future, inshallah.
شكرا. يعطيكم العافية.
شكرا.
Can we start the second session, please? Can we start the second session? I would like to introduce my colleague, Dr. Yahya Argabi. He is the chairman of Department of Medical Education at the College of Medicine in King Khalid University. And Dr. Yahya will introduce the first two speakers. Dr. Yahya.
Thanks, Professor Mnami. So our first speaker is Professor Ahmed Al-Rumayyan. He is a professor of pediatric neurology. He's the dean at the College of Medicine at King Abdulaziz bin Saud bin Abdulaziz University, and he will talk about vision and implementation. So the floor is yours, Professor Ahmed.
Assalamu alaikum wa rahmatullahi wa barakatuh. Just to add, another speaker with me is Dr. Abdullah Al-Khayal, who the Vice Dean of Clinical Affairs. First of all, I'd like to, Bismillah ar-Rahman ar-Rahim, wa salatu wa-salam ala ashraf al-Mursaleen, to thank the organizing Jamiat al-Abha, Jamiat al-Malik Khalid, ممثلة في Professor Ali Al-Qahtani, Dr. Ali Al-Na'mi, for inviting us to this exciting conference. We would like to share, first of all, with you our experience in integrating interprofessional education at the Multi-Colleges Health Sciences University. And the speakers before us make it really easy in terms of the implementations, challenges, and solutions. Dr. Ali, Dr. Ala, and Professor Gilbert. So we'll start with the first slide, please. We thought actually of presenting this together, me and my colleague, Dr. Abdullah Al-Khayal. So it will be an interprofessional presentation. Okay. The objectives is to highlight the importance of interprofessional education. We'll go through the journey of our university in integrating IPE into the curriculum, evaluations, challenges, and future directions. This is a definitions probably presented by Dr. Ala. When students from two or more professionals learn about from with each other to enable effective collaboration and improve healthcare outcome. Of course, as you can see, if they can work together, how they are going to do it and to learn together. So we are graduating a competent physicians, competent health professions. If they don't learn how to work together or how to learn together, they are going to have an effective, actually, working together. So the key is collaborations, non-hierarchies, and Prof. Gilbert talked about this, and also the effective team. What is our aim is this interprofessional educations, of course. It leads to a collaborative practice, optimal health services, and we hear actually the wisdom from Dr. Sabai about this will give you improvement of the healthcare outcome to the community. So the better interprofessional educations, of course, will lead to a better healthcare. I wouldn't say also a patient's care, but also the whole community. We are at the University of King Saud University for Health Sciences. It's a health sciences university, so an IPE is embedded in one of our goals in the strategy, and I think this has been emphasized before, that if you don't embed the IPE into the mission and the goals, implementation will be really difficult. So we had the opportunity of integrating IPE into the curriculum. We have actually 7 colleges, 7 health professional colleges: College of Medicines, College of Pharmacies, Public Health, College of Dentistry, and College of Applied, as well as College of Nursing. So we had the opportunity of working together and implementing this interprofessional education. We based it on the core competencies of IPE in regards to the interprofessional practice, the roles and the responsibilities of each professions, the communication, which is a crucial part in all aspects of learning as well as practicing. Of course, the ultimate aim is to have a teamwork working together. So what we did is that, of course, well, as Prof. Gilbert, Dr. Ali, as well as Dr. Ala, is we should have the institutional support. And one of the element is that we had IPE as one of the strategic goal. And then we had to develop the curriculum framework from all colleges, the goals, the objectives, the learning outcomes, the competencies that we need to achieve, as well as the learning objectives. Identifying the professional opportunities from all colleges through the clinical rotations, the case-based learning, simulations, facilities, and also space designing in the hospital. Collaboration with other health professions and colleges, providing faculty development, which is very important, and actually Prof. Shehri has alluded to this, which is the cornerstone of any project that you're going to implement, really. And they have to be actually the faculty development in the beginning, actually, of this project. Then we built up the assessment strategies, and we can't do this project without an evaluations. We can't do this project without getting a feedback from all the stakeholders, and from the students, from the faculties, as well as from also the organizers of those curriculums. So we established a committee, interprofessional educational committee, as maybe Prof. Ali has alluded to here in the university, And we begin our journey. So from here, and I would like to ask my colleague, Dr. Abdullah Al-Khayal, to go over this journey.
Thank you, Prof. Ahmed, and thanks to the organizing committee really for inviting us to present our work at CASAO. I was honored to be chairing the committee of the IPE after the visionary meeting between the deans from different colleges. That was in 2022. Since that time, we carried multiple activities till we reach a point of being a little bit mature, less than others, but more mature in our institution to be able to finalize and bring up a curriculum that will fit our student. So our first experience with IPE for our student was in 2022. We carried out an activity that included around 200 students from different colleges. The participating colleges at that time were the College of Medicine, College of Pharmacy, Nursing, as well as Applied Medical Sciences. 21 tutors were included from different colleges. We conducted a 2 hours session for each group. Each group was conducted between 10 and 12 students from multiple specialty. The first hour they spent it on team-based learning, where they were provided with a case that they needed to discuss among each other. Each one will define his role as according to his specialty. The second hour we spent it on doing a simulation for that case. And it was very excited, and we were very excited at the beginning. Students were very excited. We did an evaluation. Most of the evaluation after that activity were really positive. There was a clarity of the program. There is a good level of engagement of all the students. There is a good guidance from the faculty, and the simulation cases as well as the cases that were designed had a positive feedback. However, we started to get also negative experiences and negative comments from the students and from the faculty as well. The faculty were able to see that there is a different knowledges from each specialty, and their level of engagement is a little bit not equal. Students from nursing are not participating as students from medicine, and they thought that it's too much of a knowledge in term to experience to give it to them in their 2 hours session. The other comment is the duration. They thought it's very short to do a simulation as well as case-based learning in a 2 hours session, and that's mainly because of logistical issues that we needed to figure out later on. After that piloting study, we received multiple recommendations. We showed it to the deans. We presented it to the deans. And a lot of recommendation came after it, is to do more workshop for the tutors on TPL as well as simulation, how to run a simulation cases. We needed to properly orient our students on the methods that has been used, and we try to revise our cases as well as the simulation cases, especially to fit those students from the colleges like College of Applied Medical Science, where they have 9 programs there. When you present a case about acute stroke or an acute MI for a student who is in laboratory specialty, it's not going to be so interesting for them, and they didn't find it that they are really engaged in that case. It's really far from their studying. So starting the next year, which is the academic year 2022-2023, we planned 3 IPE days. In those 3 IPE days, we try to limit the student from applied medical sciences to cases that's near their specialty. We designed a lot of cases for that year just to be able to accommodate as much as possible of students. So we did 3 sessions. Each session had between 200 and 152 students from different colleges. Again, College of Medicine, Pharmacy, Applied Medical Sciences, as well as nurses. We did the same as a roundtable discussion instead of TBL, as well as simulated cases. The same case that they were discussing in the roundtable discussion, they went and simulated in the simulation center. Both students as well as faculty found it really very interesting and very beneficial for them. And they were good engagement from the student. Also, the faculty are the same, most of them are the same faculty who were involved in the piloting phase. They found it that it is more attracting now to the student when we try to gauge it to their, but also the duration was really short, and most of the comments that we got is regarding the duration. The other thing is in terms of knowledge of the students. Each student from different college will have a different experience and different knowledge. They may get experience to things that are less than other colleges. So at that time, we presented the finding of these 4 IPE to the deans, and there was a decision from the deans to try to integrate IPE within the curriculum of these colleges. They formed the IPE committee, which I was honored to share it with my colleagues as associate deans from the other colleges. And we were asked to do a needs assessment and see what are the possible topics and what are the things that are deficient in our current curriculum in each program, that we can enhance its representation in the program after, and start the design and planning for the upcoming years. We took a lot of meeting, we took a lot of discussion, we did a lot of needs assessment that I'm going to go through it in a second. So we were able to design an IPU course that was agreed up by the deans and all the colleges. It will be embedded and it will be part of the study plan of each program. It will have 1 credit hour and 2 contact hour. We try to reserve a 2 hours duration for each college. They agreed on 2 hours that they will reserve it for interprofessional education, that there is not going to be any classes or sessions scheduled at that time, so the IPA committee can put all their activity in that 2 hours per week. It will be more of a longitudinal. We will do the curriculum 2 times per year in 2 semesters, so we will have less number in each batch, that we will be able to help them more. All final year students before their internship will be involved in the IPE. It's going to be a team-based learning. We try to limit the simulation because of logistics and the number of students, as well as it's going to have a 30 contact hours of practical work.
2 more minutes.
Our course main objective is basically according to what Prof. Romayan, so for time I'm not going to go through it. On our needs assessment, when we looked at what domains though the stakeholders prefer, the top 3 were health policy, idea, and assessment, which will share all the medical specialty, doesn't need, and it doesn't depend on prior knowledge, as well as health education and research methodology. These are the 3 domains that our IPE will be concentrating on, rather than putting extra knowledge in a very busy curriculum. We created the objective of that course, and it was aligned with the MPPS program, as well as the other colleges, and the university outcome and the graduate attributes. In terms of assessment, they will be formative as well as summative assessment in form of participation and assignments, as well as a final presentation at the end of the semester. And in terms of the evaluation of the course quality, it will follow the rules of the NCAA of having end of course evaluation as well as continuous evaluation. So we are planning to start it in the academic year 2026-2027 in 2 phases. The first year it's going to be an elective course, and in the second phase it's going to be of a core course. And in terms of governance, the College of Medicine is going to be the hosting college, and it will take care of its governance as was described by previous speakers. Over this year, we carried 5 webinars so far for facilitators as an overview and overview of the concepts of IPE as well as healthcare education. What are the concepts of health policy and assessment, and what are the research methodology that's important. And by now I finished my part. Dr. Romayan will finalize the presentation.
Try to be really quick. Thank you, Dr. Abdullah, and also thank you for leading actually this really successfully. Just to say that the shared vision and mutual respect is one of the successes, institutional commitment as well as student engagement. And this is the loop, integrating the curriculum design, continuous evaluations and improvement. Of course, we have a shared challenges with all the speakers that have presented. One of the challenges is the needs for strategic commitment, the independence of each college. We have to respect the autonomy of each college, of course. The solution is to integrate IPE into the university strategic plan, embedding it in the goals of the strategy of the university. Central IPE committee has to be there, shared academic calendars, and dedicated administrative staff. One of the challenges, the limited shared spaces, of course, inadequate technologies, and managing large students. One of the solutions is identifying the university resources, and Prof. Ali actually had also mentioned this about the utilizing the best resources in the universities. Difficulty in measuring outcome, as well as dependence on the few champions instead of institutional systems. One of the solutions is to develop longitudinal evaluations and secure institutional fundings and policy support. By this, I would just summarize that there is a need for institutional support, develop a curriculum framework, identifying the interprofessional learning opportunities, collaborations with health professions colleges, faculty development, assessment strategies, and also evaluations of the IPE outcome. Thank you very much, and sorry for taking some time.
I'd like to thank Professor Ahmed Al-Romayan and Professor Abdullah Al-Khayal for their interesting talks and excellent journey. We'll take the questions at the end. I'd like to introduce my co-chair, Dr. Sandis Al-Ghamdi. She is the head of medical education at the Dentistry College, and she will introduce our next speaker.
I'd like to introduce Dr. Susan Waller. She's an adjunct senior research fellow at the Monash Rural Health. She's also faculty of medicine, nursing and health sciences, Monash University at Melbourne, Australia. Welcome, Dr. Susan.
Thank you. Assalamu alaikum. It's so wonderful to be here with you in Abha. I've been telling people I worked here 34 years ago at Bisha Hospital as a physiotherapist, and I haven't been back since. And when I came here to Khamis and Abha, I was blown away by the development that has happened here. Just amazing. I couldn't recognize the place, of course, and we flew over Bisha coming in, and I was so surprised because there was just date farms, one traffic light, and the hospital. And now, mashallah, cities underneath us. It's fantastic. But what's so wonderful is to see this university really respects the cultural traditions of the Asir region. Very happy to see the art of the women of Asir. So it's really bringing back wonderful memories. And yesterday, Professor Ali took us on a tour, and we went to the beautiful Rocky Mountains. We saw the baboons. We tasted amazing honey. And I felt 27 again, which was very exciting. So thank you very much. Thank you so much to the leadership of King Khalid University, and especially to Professor Muhammad and also to Professor Ali. It's so exciting to be here, and I'm here to share with you my experience in the United Arab Emirates. So I've worked in the United Arab Emirates as a physiotherapist and as a medical educationalist since 1996. So I first was working as a practitioner in Dubai, and I've worked in the community and in the hospital. And then I was working for the last 5 years with the College of Medicine and Health Sciences at the United Arab Emirates University. So the United Arab Emirates University is a federally funded university. It is the only public university in the UAE, completely public. So all the funds come from the court, and they are reliant on the undergraduate seats. So everything that this amazing university does, research, postgraduate programs and research, is funded by the undergraduates. So we're always very respectful of our students because we really preface the student voice, and we need to know at the UAEU that the students are coming with us in our plans and our strategies as the university moves forward. So when we thought about interprofessional education, this came with really a driver of accreditation. And, you know, so people had talked about doing learning and working together both in the university and in the practice setting for a long time, but really the driver was accreditation. And we were very fortunate that we had the support of the Commission for Academic Accreditation. So a similar body that you have for educational accreditation, we have this body. And when we started this framework development, they were in the Ministry of Education. At the start of the last academic year, all higher education moved to a new ministry called the Ministry of Higher Education and Scientific Research. So this was quite a disruptor in our working group, because the CAA moved into that particular ministry, and we had a new minister, and there were new plans and new strategies. Having said that, we have persisted, and this was the plan that we had, or the process that we had for developing the framework. And we did develop the framework, as I said, because of accreditation. So you can see these are probably very familiar steps to people, but it was basically starting off good practice with a literature review to see what was happening in the Arab world. And Dr. Ala referred to some of the findings that we had about interprofessional education in the Arab world. And we basically looked at 22 countries being the Arab world. And then we got our stakeholders together from various different institutions and different disciplines. And we had our first meeting, and we shared with them our ideas about how we could progress forward. And then we went through a modified Delphi process. So you'd know a Delphi process is where you discuss a particular topic. The people in the discussion give you feedback. You share that feedback, discuss again, and gradually the topic is developed further. And then we had a draft framework, and we circulated that to people for their comments. So our members of our working group circulated the draft domains of our competency framework with other faculty, and we got feedback from them. So then we had a hiatus because of various reasons, and now we have still a way to go before we have a final product. So we hope that we would show that to you today, but I'll tell you where we are in progress. And you can see the various colleges that are involved in our working group. And we have representatives from medicine, from nursing, from different allied health disciplines, such as physiotherapy, and of course, pharmacy as well. And I should say thank you to my pharmacy colleagues, because in the Arab world, they have really led, like Dr. Ala, the understanding of interprofessional education and collaborative practice, and also the education and research in that area. So these are the drivers that we had in developing our framework. You may have heard of the National Health Workforce Account. This is organised by the World Health Organization, and the UAE participates in that, and it helps them identify their health workforce issues and to develop their planning. And in that planning, they identified that they were only partially meeting the requirements for interprofessional education and collaborative practice. And what would give them full accreditation would be to have a national framework. So the CAA was really supporting our efforts in that way. And so we were advised that we should proceed how we expected to finish. So we looked at what sort of behavioural competencies were in EPA 9. So if you know EPAs, Entrustable Professional Activities, these are being used by medical students, but also physiotherapy students and nursing students. And this is the work that we do as health professionals. So you can see there are behavioural descriptors that will identify you as a collaborative practitioner. And Dr. Ala referred to the seminal paper from WHO that really said to us we need to produce practice-ready collaborative practitioners. Okay, so that was in 2010, and here we are in 2025, and we really need to walk the talk. So we say that we have a competency-based framework for our programs, and we really need to think about those competencies, and competencies means behaviours. We need the students to demonstrate and the faculty to role model these collaborative behaviours. And also we knew that from the start we need to have an evaluation model. And you will have seen in the literature a lot of people refer to Kirkpatrick's model with outcome evaluation. But it's very important to also evaluate the context, and a lot of our speakers have talked about the environment in which collaboration is taught and developed. We also need to know what we put into the process, what is the actual process, the teaching and learning pedagogy, and then what comes out the other end, and what's the impact of that. So thinking about a framework like the SIP framework for evaluation. So these are the domains that we came up with in our draft framework, and all of these things feed into interprofessional collaboration. And you can see similar themes that are in the Canadian framework, in the Qatar framework, in the American framework. So teamwork and team dynamics, collaborative skills and coordination, conflict management and retention. You know, the reality is there will be conflict. That conflict might be inside the team, might be outside the team, might be with the service user, the patient, with their families, but we need to know how to manage that in a respectful and quiet, steady way. And this is very important to learn as a student as well too, because you can really make the difference. And very important to develop those skills of reflective practice and continuous feedback, because again, this supports our development of collaborative competencies. So, as in Saudi Arabia, we have large expatriate population, but probably much more significant in the UAE health workforce. In some areas outside of Dubai and Abu Dhabi, there are 95% expatriate health workforce. And you would know that the Emirati population is about 11% of the population. So it's really important in the health planning, and this has been identified by the Department of Health in Abu Dhabi, that they think very deeply about how they're going to sustain their health workforce, how there's going to be continuity of care for the people in the community. And really, they think patient or person first in many cases. And I really appreciated my colleague there talking about person first, because this is all we need to know. If we think about person first, we will be collaborative practitioners. And it's very important because having so many language groups, so many communities, both as our patients or our service users and as our health practitioners, we need to make the environment culturally safe. And these are skills that you can learn as a student before you get your license. You can do this in the simulation lab, learn about how to make a culturally safe environment, and then you can further that development as a health practitioner. And you can find role models in the health service who actually create a culturally safe environment. And this is very important if you're going to be a collaborative practitioner to be able to do this. Then our next domain was roles and responsibilities, because again, we need to embrace the fact that the scope of practice of all health professions is dynamic and changing, particularly after COVID. So now we have phenomena such as the nurse practitioner. Nurse practitioners can prescribe, they can lead teams, and it's really important that we understand that also in the allied health sector, their role is expanding. And I'm very fortunate to work with the head of the Emirates Physiotherapy Society on developing this last year our scope of practice. And in that scope of practice, we were for the first time able to leave out the word technician, we're not technicians, and also include the word diagnosis, because we certainly make diagnosis about people's musculoskeletal, neurological, developmental abilities. And, you know, it's really important that we recognise the intersections, not just the separate roles, but where we work together if we're going to be collaborative practitioners. Number 3 is patient engagement, and maybe it should be number 1, very important. But, you know, it's that relationship-based therapy, so it's not just the patient. Sometimes it's the child and family. Sometimes it's the, you know, the female and male, husband and wife who are coming to see you. And it's really important that you know who is in the circle of care around that person. And if that person who's seeking service wants other people to be with them, and that can be really helpful if you're talking about management, because a lot of the management will happen in the home, they should be involved in the communication if that is what the patient wants. And care should be always guided by the needs and aspirations of the patient and the person seeking health care. So teamwork was also a domain, and I think that's common to everywhere. But the important thing is there are teams and there are teams.
5 minutes.
So there are teams
5
that
minutes
work
remaining.
really well with the leader, and everybody is led, and they're very good followers, and they all have separate roles. But there are dynamic teams too.
5 minutes remaining.
Thank you. And I'll give you an example. For instance, we were talking about an older person being discharged from hospital, and sometimes the doctor will say, okay, they're fine, they can be discharged. And the physio will say, yeah, they can walk, perhaps after some sort of fall, they can now walk safely, they can go home. But the occupational therapist has actually been in their home, and they know that they have no assistance at home. Their home is inaccessible, they have lots of steps, and there's a lot of things that have to be put in place before that person can safely go home. So they need to take the lead in that sort of situation. So those are our various domains. And we thought, because it's the UAE and the recent intensive focus on generative AI and AI-assisted healthcare, we need maybe to have a 5th domain, or we're still discussing whether we put competencies and behavioural descriptors in each of the 4 domains related to technology-assisted collaboration. Because from the electronic medical record to the person's understanding through ChatGPT about their health, we need to respect this and expect this. So we need to know how to work with this. So these are in progress, our interactions with the healthcare and the various professional associations, our interaction with some of the larger stakeholders in health service, you can see up there. And thank you very much. And if you have any advice for us about how we can ramp up our working group and finalise our national framework, there's our contacts. Dr. Iman and I are the co-facilitators of this working group, and we would always appreciate advice. Thank you.
Thank you, Dr. Waller, for that wonderful presentation. We'll take the questions after the session is over. Thank you.
Okay, thank you, Dr. Sundus. If I may introduce Prof. Suhad Al-Jundi. She's a senator, Jordanian Senate, and former Vice President of Jordan University of Science and Technology, JUST. I like the abbreviation. Professor of Pediatric Dentistry at JUST Irbid, Jordan. Prof. Suhad.
Assalamu alaikum. Assalamu alaikum wa rahmatullahi wa barakatuh. أشكركم جزيل الشكر الأورجنايزنج كوميتي وجامعة الملك خالد for the hospitality بالدرجة الأولى. It's been very nice. طبعا أنا سعيدة جدا بالعودة إلى المملكة العربية السعودية مسقط رأسي والمكان الذي تعلمت فيه في خلال سنين الدراسة في المدرسة. طبعا الشكر الجزيل لجميع القائمين على هذا المؤتمر. It's very interesting conference. And thank you for giving me the opportunity to be among you to speak on this different perspective, which is leadership role in higher education. As everyone mentioned, the interprofessional education, I'm going to time myself actually, okay? So interprofessional education has become pivotal in transforming health profession education towards teamwork, improved patient outcomes, and health system resilience. And as higher education leaders and legislators, understanding how to champion and campaign for the to institutionalize IPE is very essential. So therefore, this presentation is going to explore the multiple dimensions of leadership, policy integration, national experience, and future directions of this very important interprofessional education direction. So what is happening now with interprofessional education? As my colleagues in the previous session and in this session as well, interprofessional education, of course, gives the opportunity for students and professionals to learn from each other and with each other, and most importantly, the objective of improving collaboration and quality of care for patients. Over recent years, the Interprofessional Education Collaborative has updated some of the core competencies to include emphasis on equity, social determinants, and system-based care, reflecting the evolving health system needs, and this is very important. Globally, IPE is endorsed by the WHO and many interprofessional bodies, and it's essential for strengthening health systems. For example, the WHO has argued that fragmented professional silos hinder the attainment of universal health coverage and patient safety. Of course, as everyone mentioned previously, in the Arab region, there are many universities who are beginning to explore IPE integration, though the challenges, as mentioned by Professor John, many challenges such as tradition, siloed curricula, and as well as resource constraints, which is very important, they remain and they hinder the progress of IPE. Regional efforts in the healthcare system, such as the Saudi Arabia Vision of 2030, as well as Jordan's modernization plan, provide a very conducive environment to embed IPE in health profession training. Therefore, I am very optimistic because I think the landscape is ripe. Both academic momentum as well as political vision can align to make IPE more than just an aspiration. So, higher education is the engine for IPE. Universities and higher education institutes, of course, play a foundational role in operationalizing the IPE. They serve as laboratories for curriculum innovation, cross-disciplinary collaboration, and professional culture transformation. Leadership. I am here to talk about leadership. Leadership in universities must prioritize breaking down departmental silos, which is one of the challenges in administering IPE education. The second thing is curriculum design. Curriculum redesign is central, as mentioned by many of my colleagues, and embedding common competencies such as communication skills, teamwork, role understanding, and ethics is very mandatory across professional programs. For instance, many successful IPE curricula start with shared modules such as foundational science, ethics, and health systems before the actual profession-specific divergence. The third thing is faculty development and cross-disciplinary teaching. The development of faculty is very essential. Health profession educators may lack the experience or comfort in teaching in interprofessional settings, and therefore, systematic leadership development is very, very important, and they help the faculty with facilitation, conflict resolution, and interprofessional pedagogy skills. And this is very important before embarking on a successful IPE education. Without leaders supporting the faculty, efforts of embedding IPE will risk superficial implementation, which is not what we want. Very important to promote the culture of teamwork. It must be nurtured. Universities must reward and recognize interprofessional initiatives such as in promotion and tenure in order to make this an effort that is going to create not merely a delivery ground in higher education, but actually implement them as change agents to implement IPE. So this is just setting the stage. The leadership frameworks in higher education, in order to lead IPE transformation, academic leaders, deans, department chairs, provosts, they need to adopt robust leadership framework. And the literature highlights 3 major styles of leadership that might be conducive of IPE. First of all, transformational leadership, which emphasizes on vision, inspiring stakeholders to adopt new practices. This helps motivation of faculty and staff. The second type of leadership that might be conducive for IPE is distributed leadership. It empowers the faculty and staff, and they share leadership in teams, and this might be also conducive for IPE. The third one is servant leadership. Servant leadership emphasizes serving the needs of colleagues and reducing barriers for them. In IPE context, servant leaders attend to faculty development, resource allocation, and psychological safety. A recent review showed that leadership in health profession education identifies certain leadership characteristics such as emotional intelligence, visioning, relational capacity, and strategic thinking as essential for interprofessional leadership. In IPE interventions, leadership training that includes self-reflection, peer coaching, and practice feedback has demonstrated increased team effectiveness. Therefore, leaders must not only hold authority, but they should enable others and model desired behaviors and nurture a culture of collaboration. So, how important is bridging academia and legislation? And of course, I am wearing 2 hats today, one as an academic and one as a legislator in the Jordanian Senate. So I'm going to give more of a bird's eye perspective on this. Leadership in higher education must interface with legislations and policy systems to ensure sustainability. Really, this is the main thing. To ensure sustainability, there has to be a bridge between academia and policy making. While universities can pilot exactly as what we're doing now, universities can pilot IPE, but long-term integration often hinges on supportive policies and accreditation standards, as well as funding and governance alignment. Without that, it will be always fragmented efforts. From a policy perspective, embedding IPE into accreditation licensure requirements, and I'm happy to hear that in Riyadh they just mentioned that they did that. And so therefore, if it is integrated into accreditation and licensure requirements, it ensures that institutions cannot side it. And many standard-setting bodies globally are beginning to require interprofessional competencies in curricula, and higher education leaders should advocate for such inclusion at national quality assurance agencies. Funding. Funding is another lever for IPE. Governments may provide earmarked grants for interprofessional initiatives, simulation centers, or faculty development programs. Without funds, that is not going to work. Legislative budgets can support cross-institutional hubs as well, or national centers for IPE, which will help reduce the funds required for this. Very important, governance. Governance alignment is very crucial. Ministries of health and ministries of education have to work together in order to coordinate to avoid conflicting requirements, and academic leaders can play a role in dialogue, advising legislative committees, and monitoring policy implementation. In other words,
Prof. Suhad,
yes?
You have 5 minutes
Yes,
to conclude, please.
In short, leadership that operates only within the university is limited, and for transformation, actually I've been on for 11 minutes only. Yeah.
Because their opening ceremony is
yeah, I know. Yeah.
imminent.
Okay, anyways.
Anytime.
All right.
Sorry.
So in short, the leadership that operates only within universities is limited. True transformation demands alignment with policy ecosystems. Okay? So I will pass this one, okay, because many of my colleagues would speak about this, and I will talk about legislative perspective, shaping the ecosystem, because this is very, very important. Legislations are key in shaping educational policies, and this is legislative bodies influence the rules of the game that enables or constrains IPE. In many countries, legislative oversight ensures accountability, and this is very important to work together, and educational reforms and legislators can require reporting from universities and set national benchmarks or link funding to competencies. Legislations will also enable sustainable funding and cross-sector coordination, and therefore national policies must embed interprofessional competencies in their workforce planning. So in summary, legislators can transform pilot experiments into national systems, which is what we need here. This is very important. Digital and AI transformation in health education. How important is it? So artificial intelligence and digital technologies offer promising tools for scaling, simulating, and enhancing IPE experiences. A recent study has introduced AI-driven immersive multidisciplinary simulation, which integrates large language models and virtual environments to simulate interprofessional collaboration in realistic clinical context, and early usability results show promising fidelity and engagement across disciplines. So we can use this. AI also enhanced simulation will help overcome constraints and faculty times, physical simulation labs, and long logistical barriers to co-locating student teams. Higher education leaders and policymakers should consider investing in digital capacity as a core pillar for IPE strategy. Finally, digital literacy becomes a core competency for future health professionals, and in Jordan, the national strategy emphasizes ethical and applied integration. Without policy support, digital innovation risks being siloed or underutilized. For the regional and global synergies, which are very, very important, interprofessional education thrives when institutions collaborate across borders, sharing curricula. And I'm really happy to see that there is a lot of collaboration here and this conference where a lot of Arab countries are joined and also international, and this is really the goal. Global organizations also, such as the WHO and the Center for Advancement of Interprofessional Education and Interprofessional Education Journals, serve as critical knowledge hubs as well. Collaborations will also allow smaller institutes to access and share simulation resources and therefore reduce the burden of budgetary requirements. Recommendations for academic leaders and policymakers. First of all, based on the landscape and challenges, the following recommendations are suggested. First of all, institutionalizing IPE through accreditation and licensure standards and embedding the competencies into national accreditation bodies and professional licensing exams. Second, embedding IPE in national higher education policy is very, very important. Ministries of Education and Health should require universities to include IPE as part of core curriculum standard, linking funding to qualitative evaluation, foster regional research and funding networks, exactly as we are doing now and exactly as the collaboration is doing. Then invest in digital and AI integration into the curricula. This is very, very important because it will reduce the time and effort into implementing this, and then strengthening the governance and multi-sector coordination is very, very important. We need to create interministerial cooperation where health, education, and science will align, as well as research in this area. And finally, support leadership development program, as well as continuous monitoring and evaluation of the outcome. Conclusion, and this is my final slide. Leadership in higher education is definitely key in advancing IPE, and higher education leaders and legislation share an essential responsibility of advancing IPE. In universities, leaders must champion structural change, facilitate faculty development, and foster a culture of collaboration. And in the legislative, advocacy will ensure the sustainability. Together, bridging academia and legislative authority offers a powerful synergy to transform health profession education and ultimately strengthen health systems in the Arab world and everywhere and beyond. And thank you so much for letting me give this opportunity being with you in this conference.
Thank you, Prof. Suhad.
Thank you.
If I may invite the speakers to come up on the stage, please, to entertain some questions, please, quickly. Dr. Hussein. Microphone, please. You can speak loudly, Dr. Hussein, until the microphone comes.
Thank you so much. It's indeed a great pleasure to see this momentum in the interprofessional education moving forward, where the medical, nursing, dentistry, pharmacy, schools, and all other health colleges are coming together, and with the deans committees, education training evaluation commission, ministers council, moving forward with this long-awaited momentum for the interprofessional education in the health professional education. I hope that the next step, and it could be one of the recommendations of this conference, is that we move forward to the trans-professional or transdisciplinary education, where we see our medical students, dentistry, pharmacy, nursing students studying, working, learning together with their peers in the computer, engineering sciences, social sciences, law, business, and others, addressing solutions and addressing issues, challenges, and coming together to bring up solutions, whether undergraduate or postgraduate education level. Ethical, responsible utilization of AI, the legal consequences of the emerging technologies, building solutions from the scratch all the way up together, addressing issues that probably would not be addressed otherwise, and learning through these issues when the law, business, technology, health professions, students, trainees, and professionals reach to that, I think we will have an accelerated way of learning and moving forward in the health sector.
Thank you,
so
Dr. Hussein. I will leave the stage now for the opening ceremony. Thank you.
الحمد لله صاحب المنة والفضل الذي علم الإنسان ما لم يعلم وأسبغ علينا بنعمة العلم والحكمة وجعل من التعاون والتكامل طريقاً للتقدم والنهضة. والصلاة والسلام على خير معلم نبينا محمد وعلى آله وصحبه أجمعين. أما بعد، معالي رئيس جامعة الملك خالد، أصحاب المعالي والسعادة، ضيوفنا الأكارم، أيها الحفل الكريم، نلتقي هذا اليوم في رحاب العلم، حيث تسمو القيم وترتقي الرسالة ويتجدد العطاء. نستحضر بكل فخر واعتزاز ما تحظى به مسيرة التعليم والصحة في وطننا الغالي من دعم كريم ورعاية سديدة من مقام سيدي خادم الحرمين الشريفين الملك سلمان بن عبد العزيز آل سعود، وسمو ولي عهده الأمين رئيس مجلس الوزراء صاحب السمو الملكي الأمير محمد بن سلمان بن عبد العزيز حفظهم الله، اللذين جعلا الاستثمار في الإنسان وتنمية القدرات الوطنية ركيزة لتحقيق نهضة تعليمية وصحية رائدة تتجسد معالمها في رؤية المملكة 2030 وبرامجها الطموحة لبناء مستقبل تنافسي قائم على المعرفة والابتكار والتكامل. ومما يزيد هذا المؤتمر تشريفاً بأن يأتي برعاية كريمة من صاحب السمو الملكي الأمير تركي بن طلال بن عبد العزيز آل سعود، أمير منطقة عسير ورئيس هيئة تطويرها حفظه الله، ذلك الدعم الذي يجسد اهتمام القيادة الرشيدة بتطوير الإنسان وتمكين المعرفة والارتقاء بجودة الحياة، ويعكس ما تحظى به منطقة عسير من عناية خاصة في مسيرتها التنموية والعلمية. أصحاب المعالي والسعادة، ضيوفنا الكرام، نرحب بكم أجمل ترحيب، كما نرحب بنخبة من العلماء ورواد التعليم الصحي والممارسين الصحيين من داخل المملكة وخارجها، كما نرحب بالشركاء الاستراتيجيين والجهات الصحية والأكاديمية المشاركة وبكل من حضر ليسهم معنا في صناعة المعرفة وتوسيع آفاق التعاون العلمي. إننا اليوم نقف أمام محطة علمية مهمة تجمعنا في المؤتمر الدولي الثاني لاستراتيجيات التعليم الصحي المتداخل والممارسات التعاونية الفعالة، سد الفجوة وقياس التأثير، والذي يأتي استمراراً لمسيرة الريادة التي تتبناها جامعة الملك خالد في تطوير التعليم الصحي والارتقاء بجودته وفق أعلى معايير التميز والريادة. أيها الحضور الكريم، نستفتح فقرات حفلنا المبارك بخير ما نبدأ به كلام الله عز وجل تلاوة عطرة يتلوها علينا الطالب بكلية الطب سعيد مرعي الأحمري، فليتفضل مشكورا.
أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. وما تكون في شأن وما تتلو منه من قرآن ولا تعملون من عمل ولا تعملون من عمل إلا كنا عليكم شهودا إذ تفيضون فيه وما يعزب عن ربك من مثقال ذرة في الأرض ولا في السماء ولا أصغر من ذلك ولا أكبر إلا في كتاب مبين. ألا إن أولياء الله لا خوف عليهم ولا هم يحزنون الذين آمنوا وكانوا يتقون لهم البشرى في الحياة الدنيا وفي الآخرة لا تبديل لكلمات الله ذلك هو الفوز العظيم. ولا يحزنك قولهم إن العزة لله جميعا هو السميع العليم.
ندعوكم لمشاهدة هذا العرض المرئي الذي يجسد مسيرة جامعة الملك خالد وريادتها العلمية ويبرز ارتباطها برسالة هذا المؤتمر وأهدافه السامية.
من أبهى البهية عاصمة السياحة، حيث يعانق السحاب الجبال وتنبض الحياة بجمالها الطبيعي وترسم لوحات من الجمال والكمال. عسير، أرض الشيم والقيم، والمكان الذي يجمع بين أصالة الماضي وحداثة الحاضر. وتطل من الأفق جامعة الملك خالد، منارة من منارات العلم والمعرفة، ومن بين أروقة رحابها تشع كلية الطب بنور العلم والتقدم، واضعة في أولوياتها ريادة التعليم الطبي في المملكة من خلال توظيف أحدث ما توصلت إليه العلوم والتقنيات الحديثة. وينهل طلابها من تنوع طرق التعلم والتدريس والتقويم باستخدام الأساليب الحديثة، وذلك عبر خطط دراسية جديدة ومطورة تراعي احتياجات القطاع الصحي وتنسجم مع متطلبات التطوير والتحول في الخدمات الصحية بالمملكة، وتتواءم مع استراتيجية منطقة عسير ورؤية المملكة 2030.
نرحب بالضيوف الكرام، فأهلا وسهلا ومرحبا وحياكم الله في جامعتكم جامعة الملك خالد، منارة من منارات العلم والمعرفة.
وتعمل الكليات الصحية بجامعة الملك خالد على إعداد ممارسين صحيين متميزين يمتلكون المعرفة العلمية والمهارات السريرية اللازمة في التشخيص والعلاج، إلى جانب تعزيز روح العمل الجماعي كفريق متكامل لتقديم رعاية صحية متقدمة وشاملة من خلال مستشفيات ومراكز تغطي جميع التخصصات الطبية والصحية. وها هي كلية الطب في هذا اليوم تفتح قلبها وذراعيها لاستضافة المؤتمر الدولي الثاني لاستراتيجيات التعليم الصحي المتداخل والممارسة التعاونية الفعالة، بالتعاون مع الشبكة العربية للتعاون بين المهن الصحية والجمعية السعودية للتعليم الطبي، والذي يحمل بين طياته آفاق المستقبل تحت شعار سد الفجوة وقياس التأثير.
يشرفنا أن نكون معكم في المؤتمر الثاني للشبكة العربية للتعاون بين المهن الصحية حول التعليم الصحي المتداخل والممارسة التعاونية، الذي تستضيفه جامعة الملك خالد في أبها. لقد انطلقت مسيرة شبكتنا من جامعة قطر، حيث استضفنا النسخة الافتتاحية ورسخنا نماذج وبرامج عملية في التعليم الصحي المتداخل أثبتت أثرها على مخرجات التعلم وجودة الرعاية. ومن الدوحة إلى أبها ننقل اليوم خبراتنا ونوسع نطاقها إقليمياً تحت شعار سد الفجوة وقياس الأثر. فقد تجاوزنا مرحلة الدعوة العامة إلى التطبيق القابل للقياس الذي يظهر في التعليم الكلينيكي والعمل الجماعي داخل ميادين الرعاية. الشبكة العربية للتعاون بين المهن الصحية جزء فاعل من الاتحاد العالمي للتعليم والممارسات الصحية المتداخلة. نحمل صوت منطقتنا إلى النقاش العالمي ونسهم في تحديد الأولويات وصياغة المعايير، ونعود إلى جامعاتنا ومؤسساتنا بأفضل الممارسات المبنية على الأدلة مما يعزز الجودة ويعمم الفائدة. وبالشراكة مع جامعة الملك خالد وشبكة شركائنا في الوطن العربي سنعمل على معايير مشتركة وأدوات عملية تمكن الأكاديميين والممارسين من تحسين التعاون وجودة الرعاية والخدمات على مستوى المنطقة. وبهذه المناسبة أتوجه بخالص الشكر والتقدير لجامعة الملك خالد على سخائها وحفاوة ضيافتها وعلى جهودها الكبيرة في تنظيم هذا الحدث المتميز. نتطلع إلى يومين حافلين بالحوار البناء وشراكات ممتدة وأثر ملموس يربط المنطقة العربية بالنقاش العالمي تحت مظلة الاتحاد العالمي للتعليم والممارسات الصحية المتداخلة interprofessional.global.
ومن المتوقع أن يسهم هذا المؤتمر في تطوير المناهج الدراسية وتحسين مخرجات التعلم ورفع كفاءة الممارسين الصحيين.
Welcome to King Khalid University, hosting the second international conference on interprofessional education and collaborative practice effectiveness, including bridging the gap and measuring the impact. This conference stems from the first conference held in 2015 in Qatar under the umbrella of Arab National Interprofessional Network, which is also part of a global confederation hosting many networks all over the world for a purpose of exchanging experiences, sharing research, and improving interprofessional education and collaborative practice worldwide. Our conference is rich in lectures by eminent experts in the field. We have also 4 workshops, as well as 22 posters, including exhibition and exhibitors representing healthcare models, as well as educational agents and company presentations. We hope that participants will benefit from this conference and pave the way for them to plan and implement interprofessional education and collaborative practice in their institutes, as well as we hope that this conference will be a turning moment for King Khalid University.
ويهدف المؤتمر إلى تعزيز العمل الجماعي بين المهن الصحية، تبادل المعرفة بين الكليات الصحية والمؤسسات العالمية، إنشاء إطار مؤسسي للتعليم المهني المتداخل والممارسة التعاونية. فأهلاً وسهلاً بكم نحو مستقبل طبي مشرق ومتطور في رحاب جامعة الملك خالد، حيث يلتقي الإبداع بالمعرفة.
أيها الحفل الكريم، في مسيرة العلم هناك من يصنع الأثر ويقود العمل بروح المسؤولية ورسالة المعرفة، وامتداداً لعطاء كلية الطب وجهودها في تطوير التعليم الصحي وتعزيز رسالتها الوطنية والأكاديمية. يسعدنا في هذه اللحظة أن نستمع إلى كلمة سعادة عميد كلية الطب ورئيس اللجنة التنظيمية للمؤتمر الأستاذ الدكتور علي بن سعيد القحطاني، فليتفضل مشكورا.
بسم الله الرحمن الرحيم. الحمد لله رب العالمين، وصلى الله وسلم على نبينا محمد وعلى آله وصحابته أجمعين. ابتداء أود أن أرحب بالضيوف الكرام أجمل ترحيب. ويأتي هذا اللقاء برعاية كريمة من صاحب السمو الملكي الأمير تركي بن عبد العزيز أمير منطقة عسير راعي هذا الحفل يحفظه الله، معالي رئيس جامعة الملك خالد، أصحاب المعالي والسعادة، الضيوف الكرام، السلام عليكم ورحمة الله وبركاته. يطيب لنا في جامعة الملك خالد أن نرحب بكم أجمل ترحيب في رحاب هذا الصرح العلمي العريق، وفي مناسبة علمية مميزة ينعقد فيها المؤتمر الثاني الدولي لاستراتيجيات التعليم الصحي المشترك والممارسة التعاونية الفعالة. يحمل في طياته آمال المستقبل تحت شعار سد الفجوة وقياس التأثير. هذا المؤتمر يجسد التزام الجامعة برسالتها في تعزيز التكامل بين التخصصات الصحية ودعم مفاهيم التعليم التعاوني والممارسة المشتركة بما يواكب تطلعات رؤية المملكة 2030 وينسجم مع متطلبات التحول في الخدمات الصحية في المملكة العربية السعودية، ويتوافق مع استراتيجية منطقة عسير نحو نظام صحي متكامل قائم على الكفاءة والجودة في خدمة الإنسان. يأتي هذا اللقاء امتداد للتطورات الحديثة في التعليم الطبي المتداخل للكليات الصحية ليعزز مفهوم التعاون والعمل الجماعي وتبادل المعرفة مع الالتزام بأخلاقيات المهنة وتقديم أفضل خدمة ممكنة للمريض وبأعلى معايير الجودة. يهدف المؤتمر إلى تعزيز العمل الجماعي وتبادل الخبرات بين الكليات الصحية والمؤسسات العالمية المناظرة مع تطوير المناهج ومخرجات التعلم وإعادة هيكلة البرامج الأكاديمية بما يتوائم مع مبادرات الجامعات ومزايا الكليات الصحية، إضافة إلى إنشاء إطار مؤسسي للتعليم المهني المتداخل. إنه من دواعي سرورنا وفخرنا اليوم مشاركة نخبة من العلماء والقياديين والخبراء الدوليين المتخصصين في التعليم الطبي المتداخل والممارسة التعاونية بين مختلف دول العالم، بالتعاون مع الشبكة العربية للتعاون بين المهن الصحية وكذلك الجمعية السعودية للتعليم الطبي بجامعة الملك خالد. يجتمع الجميع لتبادل الخبرات واستعراض أفضل الممارسات والبحوث التي تسهم في تطوير التعليم الصحي المشترك وتحسين مخرجات التعلم بما يخدم المجتمع والإنسانية. ختاماً أتقدم بخالص الشكر والتقدير لكل من أسهم في إقامة هذا المؤتمر، وأخص بالشكر معالي رئيس الجامعة على دعمه اللامحدود، وكذلك اللجنة العلمية والشبكة العربية وجمعية التعليم الطبي السعودي ورعاة المؤتمر الكرام، مجموعة تداوي الطبية، الشريك الاستراتيجي ومجموعة مستشفيات الحياة الوطني ومجموعة السعودي الألماني الرعاة الماسيين، وكذلك مستشفى أبها الخاص العالمي الراعي الذهبي. أكرر الترحيب بالضيوف الكرام، فأهلا وسهلا ومرحبا بكم في جامعتكم، جامعة الملك خالد، منارة من منارات العلم والمعرفة، ومرحبا بكم في عسير، أرض القمم والشيم، حيث يجتمع الإبداع مع الجمال وتلتقي القيم مع القمم. والسلام عليكم ورحمة الله وبركاته.
أيها الحفل الكريم، لا تنهض الجامعات إلا حين تملك قيادة تدرك قيمة المعرفة وتؤمن بدور المؤسسات الأكاديمية في صناعة المستقبل، وتمنح التعليم مكانته بوصفه استثماراً في الإنسان قبل أن يكون نظاماً ومنهج. وفي مسيرة جامعة الملك خالد كان للدعم الذي تحظى به من قيادتها أثر بالغ في تعزيز مكانتها العالمية وتطوير بيئتها التعليمية والبحثية وخدمة رسالتها الوطنية. لقد كان معالي الأستاذ الدكتور فالح بن رجاء الله السلمي رئيس جامعة الملك خالد حاضراً بفكره وتوجيهه ورعايته لمسارات التطوير في الجامعة، ومؤمناً بدورها في دعم النهضة التعليمية والصحية التي تعيشها المملكة، ومسانداً للمبادرات النوعية التي تعزز تكامل المعرفة بين التخصصات، ومنها هذا المؤتمر الذي يجسد رؤية الجامعة في التكامل الصحي والتعاون المهني والابتكار في التعليم. وإننا في هذا المقام نتقدم لمعاليه بوافر الشكر والتقدير على دعمه المستمر لهذا المؤتمر العلمي وثقته بأهمية العمل الأكاديمي الجاد القادر على إحداث الأثر وخدمة أهداف رؤية المملكة 2030. نترككم الآن مع كلمة معاليه، فليتفضل مشكورا.
بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف الأنبياء والمرسلين نبينا محمد وعلى آله وصحبه وسلم. أصحاب المعالي والسعادة، ضيوف المؤتمر الدولي الثاني لاستراتيجيات التعليم الصحي المتداخل والممارسة التعاونية الفعالة، الذي يقام تحت شعار سد الفجوة وقياس التأثير. أصحاب السعادة، عمداء كليات الطب في جامعات المملكة وجامعات دول مجلس التعاون، وعمداء كلية الطب بجامعة الملك خالد عبر تاريخها الممتد، الحضور الكرام، زملاء والزميلات، الشركاء والرعاة، طلاب والطالبات الأعزاء، السلام عليكم ورحمة الله وبركاته. ويسعدني أن أجدد الترحيب بكم في جامعتكم جامعة الملك خالد، التي حظيت وتحظى دائما بفضل قيادة مولاي خادم الحرمين الشريفين الملك سلمان بن عبد العزيز آل سعود حفظه الله، وسمو سيدي ولي عهده الأمين رئيس مجلس الوزراء صاحب السمو الملك الأمير محمد بن سلمان بن عبد العزيز حفظه الله، بكامل الدعم والرعاية والاهتمام لتكون جزءاً من منظومتنا الوطنية التي تواصل العمل ليل نهار لصناعة التنمية والبناء والعطاء لتحقيق تطلعات الوطن وقيادته. الأخوة والأخوات، يقام هذا المؤتمر برعاية كريمة من سيدي صاحب السمو الملك الأمير تركي بن طلال بن عبد العزيز آل سعود أمير منطقة عسير ورئيس هيئة تطويرها، في إطار اهتمامه حفظه الله بجامعة الملك خالد ودعمه الدائم لبرامجها وأنشطتها كأحد الممكنات الرئيسية لتحقيق استراتيجية تطوير منطقة عسير المنبثقة من رؤية السعودية 2030. فشكراً لسموه الكريم. كما يأتي المؤتمر ترجمة حقيقية لاهتمام وزارة التعليم ومجلس شؤون الجامعات، وانعكاساً لاستراتيجية جامعة الملك خالد 2030 المتوائمة مع استراتيجية تطوير منطقة عسير، والتي جعلت علوم الصحة إحدى أولوياتها البحثية. الحضور الكرام، مهما تعددت رسائل الجامعات ووظائفها وتشكلت عبر المراحل الزمنية على نحو معين، إلا أن الشأن التعليمي يبقى هو الجوهر والأساس، ومنه تنطلق الوظائف الأخرى للجامعات من بحث علمي وابتكار وخدمة للمجتمع وإسهاماً في تحقيق التنمية المستدامة. ومن هنا عملت جامعة الملك خالد على التركيز في هذا المؤتمر وفي المؤتمر الأول الذي عقد في عام 2022 على تسليط الضوء على التعليم الطبي إيماناً بأهميته البالغة. الأخوة والأخوات، شرفنا وسعدنا وشرفت جامعة الملك خالد ومنطقة عسير بحضوركم ومشاركتكم، فكل منكم يحمل تجربة ثرية، وتتعدد وتتنوع التجارب لضيوف هذا المؤتمر بتنوع التكوين العلمي والبحثي والمرجعيات المعرفية، لتشكل مزيجاً من التقاليد الأكاديمية والأبعاد والتوجهات التي نامل أن نفيد منها بإذن الله جميعاً. الحضور الكرام، لقد حرصنا بالتنسيق مع اللجان المختصة بالمؤتمر على أن لا يكون مجرد تجمع وطرحاً للأوراق العلمية المتخصصة، وإنما سوف يشكل بإذن الله تجربة علمية ثرية ومتكاملة من خلال المعارض المصاحبة بالتعاون مع عدد من الجهات ذات القيمة والأثر في المجال الصحي، ومن خلال الورش وتبادل الخبرات والأفكار والتجارب، والحضور البارز للطلاب والطالبات والمختصين، وهو البعد العلمي والبحثي الذي يكمله البعد الاجتماعي، متمثلاً في تكريم من يستحقون التكريم عبر تاريخ كلية الطب بجامعة الملك خالد الممتد لأكثر من 47 عاماً، وعبر العديد من البرامج الاجتماعية التي حرص القائمون على المؤتمر على إعدادها. الأخوة والأخوات، جاء هذا المؤتمر بالتعاون مع الشبكة العربية للتعاون بين المهن الصحية والجمعية السعودية للتعليم الطبي بجامعة الملك خالد والجهات الأخرى، وهو تكامل متميز يمنح المؤتمر أبعاداً علمية ومهنية، كما كان لشركائنا وللرعاة من القطاع الخاص حضوراً يدعو إلى الفخر ويجسد إيمانهم العميق بدعم المعرفة وتعزيز الوعي وتسخير جهودهم وجهود مؤسساتهم في خدمة هذا الحدث العلمي المهم، فلهم منا كل الشكر والتقدير والامتنان. ختاماً، أكرر الترحيب وأجدد الشكر لكل من ساهم في تنظيم هذا المؤتمر، وأخص بالشكر كلية الطب، هذه الكلية المتميزة والرائدة على مستوى جامعة الملك خالد وعلى مستوى جامعات الوطن. والسلام عليكم ورحمة الله وبركاته.
سعى العلماء لرفع الناس في شرف، وكنتم القادة الأوفى ومن خدموا. من نوركم يتسامى الطب مزدهراً، ويزهو العلم إذا ما ذكرت همم. أيها الحفل الكريم، الوفاء قيمة لا تصنعها الكلمات بل تصنعها المواقف، والنجاح لا يبدأ من فراغ بل تبنيه سواعد مخلصة آمنت بالرسالة منذ بدايتها. واليوم وفي لمسة وفاء واعتزاز وافتخار بتاريخ هذا الصرح الطبي العريق، تحتفي جامعة الملك خالد ممثلة بكلية الطب بمن وضعوا لبنة الأساس الأولى لهذا الكيان قبل 47 عاماً. أولئك الذين حملوا الأمانة وأسهموا في بناء جيل بعد جيل من الأطباء والخبراء والممارسين الصحيين في خدمة هذا الوطن المعطاء. وبكل فخر تقف كلية الطب تقديراً وامتناناً لعمدائها السابقين الذين قادوا مسيرتها خلال مراحلها التأسيسية والتطويرية، وكانوا جزءاً من حضورها الأكاديمي وتاريخها المهني. ولهذا ندعو أصحاب المعالي والسعادة عمداء كلية الطب السابقين للتفضل بالصعود واستلام دروع الوفاء والعرفان والتقاط صورة تذكارية مع معالي رئيس الجامعة تقديراً لمسيرتهم وإخلاص عطائهم، وهم سعادة الأستاذ الدكتور زهير بن أحمد السباعي، سعادة الأستاذ الدكتور غازي بن عبد اللطيف جمجوم، سعادة الأستاذ الدكتور عبد العزيز بن حسن الصايغ، معالي الأستاذ الدكتور محمد بن يحيى الشهري، سعادة الأستاذ الدكتور سعيد بن علي أبو عشي، سعادة الأستاذ الدكتور محمد بن عطية الحمراني. سعادة الأستاذ الدكتور محمد بن عوض الحميدي. سعادة الأستاذ الدكتور علي بن محمد آل بن علي. سعادة الأستاذ الدكتور عبد الله بن سعيد عسيري. سعادة الأستاذ الدكتور سليمان بن محمد الحميد.
تكريم المتحدثين المشاركين تقديراً لمساهمتهم العلمية في جلسات المؤتمر، نرجو من المتحدثين الكرام التفضل بالصعود إلى المنصة لاستلام دروع التكريم والتقاط صور تذكارية مع معالي رئيس الجامعة، وهم Professor John Humphrey Gilbert, Professor Barbara Maxwell, دكتور علاء عبد الفتاح العويسي، الأستاذ الدكتور زيد محمد عيسى الحمدان، الأستاذ الدكتور هالة أحمد عبد البوادي، دكتور إيمان محمد موسى اللباد، دكتور سوزان والر، الأستاذ الدكتور سلمان يوسف، دكتور دينا نادر، الأستاذ الدكتور محمود عديل، دكتور شالانة عمر، الأستاذ الدكتور سراج علي محمد، دكتور عبد الله الخيال، الأستاذ الدكتور محمد بن يحيى محمد النعمي، الأستاذ الدكتور هاني عباس النوافلة، الأستاذ الدكتور سهاد حسين صالح الجندي، دكتور منى حمود الشيخ، الأستاذ الدكتور محمد عبد الله المنصور، دكتور هاني علي الغامدي، الأستاذ الدكتور أحمد رميان الرميان، الأستاذ الدكتور علي سعيد محمد القحطاني. يأتي هذا النجاح ثمرة لعمل جماعي وجهود مخلصة تقف خلف التنظيم والإتقان العلمي. تقديراً لجهود اللجنة العلمية في إنجاح هذا المؤتمر، ندعو رئيس اللجنة العلمية وأعضاءها للتفضل بالصعود إلى المنصة لاستلام دروع التكريم والتقاط صور تذكارية مع معالي رئيس الجامعة، وهم الأستاذ الدكتور محمد بن يحيى النعمي، الأستاذ الدكتور عبد العزيز بن عوض العمري، دكتور حسن بن علي الزهراني، المهندس الدكتور عبد الله عبد الرحمن العياشان، دكتور ريان إبراهيم بن دحيم، دكتور هبة علي اليزيدي، الدكتور ناصر محمد القحطاني، الأستاذ الدكتور محمد آل منصور.
أيها الحفل الكريم، نتقدم بخالص الشكر والتقدير للرعاة والداعمين الكرام الذين كان لإسهامهم أثر واضح في إنجاح هذا المؤتمر ودعم رسالته العلمية والطبية. إن وقوفهم إلى جانب المعرفة والبحث العلمي يجسد شراكة واعية تسهم في خدمة الإنسان وتنمية المجتمع. والرعاة هم مجموعة تداوي الطبية، الشريك الاستراتيجي، مجموعة مستشفيات الحياة الوطني، الراعي الماسي، مجموعة السعودي الألماني الصحية، الراعي الماسي، مستشفى أبها الخاص العالمي، الراعي الذهبي، ختاماً وباسم جامعة الملك خالد نطوي ختام هذا الحفل وقد جمعنا هدف واحد: أن نحول التعليم الصحي المتداخل من شعار إلى أثر، ومن تعاون إلى إنجاز، ومن فجوة إلى تكامل وقياس تأثير. شكراً لحضوركم وعطائكم، وإلى لقاء يتجدد بالعلم والعمل. كان معكم محدثكم من كلية الطب مازن بن خالد آل الشيخ،
ومحدثكم بكلية الطب نواف بن يحيى الجابري. والسلام عليكم ورحمة الله تعالى وبركاته.
Hey, check. Hey, hey. check, check, hey.
بسم الله الرحمن الرحيم. تشيك 1. بسم الله الرحمن الرحيم. تشيك 1. بسم الله الرحمن الرحيم. بسم الله الرحمن الرحيم. بسم الله. تشيك 1. بسم الله الرحمن الرحيم. بسم الله الرحمن الرحيم. تشيك 1. بسم الله الرحمن الرحيم. تشيك 1. بسم الله الرحمن الرحيم. تشيك 1. بسم الله الرحمن الرحيم. بسم الله. تشيك 1. بسم الله تشيك 1. بسم الله 1 2 3. بسم الله. بسم الله الرحمن الرحيم. تشيك 1 2. بسم الله الرحمن. بسم الله. بسم الله الرحمن الرحيم. تشيك 1 2. بسم الله الرحمن الرحيم. بسم الله الرحمن الرحيم. تشيك 1 2. بسم الله. بسم الله الرحمن الرحيم. تشيك 1 2. بسم الله. تشيك 1 2 3. بسم الله. بسم الله الرحمن الرحيم. تشيك 1 2. بسم الله.
1 2 3 1 2 3. بسم الله الرحمن الرحيم. I'm Dr. Adil Hassan al-Shehri, consultant infectious disease and clinical microbiology, the chief medical officer of Saudi German Hospital, branch Asir. First of all, I would like to, on behalf of Saudi German Health, to express our greatest gratitude to King Khalid University for giving us this opportunity to participate as a sponsor in this international event, and sincerely congratulate the university leadership for the recent achievement on university ranking according to Times Higher Education, and second for this beautiful organization of this event. Interprofessional education, bridging the gap and measuring the impact. I believe our respected speaker has spoken about very important terminology, so I will not go through it. However, I will emphasize on the point of that it's need an effective collaboration. So in order to have a measurable impact in regard to interprofessional health education, we need to have not only collaboration, but effective collaboration. So it is not only collaboration when we deal with the health learning system, it is a combination of extra informatics, incentives, and most importantly, culture to achieve an effective learning health system. We at Saudi German Health, and particularly in the southern region of Saudi Arabia, the Asir region, we are part of the largest healthcare network in the MENA region, Middle East, and North Africa. We believe that in order to provide an excellent, outstanding medical health, that this framework that had been presented many times during the previous speech to be implemented. And we believe that the medical quality that we are providing in private sector is dependent on a continuous medical education, and most importantly in the recent era is to have an effective interprofessional medical education. And we believe that the starting point is from assessing the local health need, going throughout all the process of this framework to have an improved health outcomes. I will just show some of our achievement in Saudi German Health throughout previous years. We are a group of, as we mentioned before, that we are the largest network of medical health in the private sector in Middle East and North Africa, with more than 22 medical institutes that has almost 35 years of experience and more than 3,900 beds that provide not only the medical care for our patient, but medical education. We are proud that on a yearly basis, evaluating and treating and participating in medical care for more than 2.5 million, and with more than 44 medical specialties in the whole medical field. We have more than 9,000 employees in this network. And more recently, as we believe that the medical quality is accompanied by effective medical education and collaboration with a leader in the medical health and medical education, we have signed recently an agreement to be affiliated with the international leaders like Mayo Clinic. We have more than 20 accreditation in our hospital. Lastly, received within the last few months the Magnet accreditation, and we are the only one from Kingdom Saudi Arabia that recognized as Magnet member, and we receive our recognition in ceremony held in USA almost 3 weeks back. In regard to the health collaboration with the leaders in the field, as we mentioned, we have signed an agreement with the leaders like Mayo Clinic. We are proud to have this collaboration, international collaboration, to bring the local excellence to our area and to our patient and to our employees. The celebration or ceremony for this agreement done almost 3 weeks from now in Riyadh. As we are speaking about education, it is important to show that we strive in Saudi German Health to have the highest standard in medical education. So we are the first hospital in a private sector that gets the full institutional accreditation to have the residency program and to be a teaching hospital, not only for undergraduate, but for postgraduate students. So this agreement or recognition or accreditation from Saudi Commission have resulted in more than 9 programs opened in our hospital. We are the only or the first hospital in private sector in South region to have a well-structured, accredited program by Saudi Commission for health specialties in following specialties: orthopedic, OB/GYN, internal medicine, ICU, emergency department, and pediatric, general surgery, and anesthesia. So we are lucky that in the beginning of this October, we have received our colleagues from the first batch of residents. Almost 53 residents joined our hospital for training purposes. Those residents will be graduated, inshallah, after their finishing their program to be effective professional doctors in their specialties, serving the other hospitals in the region. We are, as our aim to improve our medical quality and the clinical teaching for our residents, we are also concentrating on the quality of trainers. So we are one of the centers that provide TOT courses for our consultant and the consultant in the regions that are interested in medical education. So we have conducted multiple courses that resulted in more than 60 of our faculty accredited with TOT. In regard to our collaboration with the our governmental institute that work in the medical education. We have an agreement with our health academy related to the Saudi Commission for Health Specialties. And soon we will open more of the training program, not only for the doctors, but for the healthcare providers in the following specialties: nursing, dental assistant, ECG technicians, and patient care technician. Inshallah, those trainees will be an effective staff in our hospital in the region after their graduation. And it is worthy to mention that after their graduation from our hospital, they will be officially licensed by the Saudi Commission for their professions, in order also to have a better collaboration with other international and national society. We are accredited Center for Saudi Heart Association. We have conducted more than 226 sessions for the last, or courses for life support courses, with more than 1,500 participants who were enrolled in these programs. Also, in regard to collaboration with the Medical Education Institute, we have an agreement between our group and Batarji Medical College to be the training hospital for their student, whether the student of the medical college or student of other allied medical services. And we have graduated the first batch of internal medicine student last year. We have these programs in joining or with agreement with medical or Batarji Medical College to provide these programs, because we are believing that the medical education is not only depend on education itself, but it is it's a huge part of it is medical research. We are accredited center also for medical researches from King Abdulaziz City for Science and Technology. We have an active IRB committee. We are conducting medical research in every specialties in medical health. We are proud to share with you that we have a lot of publications, especially last year. Some of them have been published in significant or high index journals. Because we are also striving to have a quality medical research and empowering women. So the group have recruited figures in medical education. So Dr. Ashwag is a well-known figure in medical research in the kingdom, have joined our group to have a proper structure of the medical researches and to build research centers in all of the hospitals related to Saudi German health. We have agreement for medical education with Asir Health Cluster as well as Jazan Health Cluster. In regard to continuous professional education, we are regular provider of multiple courses for the medical professional, whether in our hospital or the hospital in the regions. We have conducted more than 230 of continuous medical education hours in this year. The greatest achievement that we have is agreement of collaboration between King Khalid University and Asir Asir branch to participate in medical education in both parties, and to have the medical students to be trained in our hospital as well. We have an agreement with the Armed Forces Hospital in the southern region. It is always nice to sit back and remember when we started. The Saudi German Health is an old institute that have been started in 1940. And with the years, we have not only expanded in building and distribution throughout the years and places, but we more recently concentrated on medical education with the leadership of His Excellency Mr. Makarib, that he is carrying now the major transformation in the medical quality and medical education in the group. Our ever-expanding international footprint, as you can see, we are a group that expanding from Morocco in Africa till Pakistan. It is recently announced that we have scholarships funded by Batirji Medical School. So it is for our students to, if they are interested, these completely funded by Batirji Medical School, to have the excellent student seeking their future, inshallah. This is a picture for our hospital, and this picture is almost 20 years old. As you can see, it was built in an area where there is no building around it. Now we are proud that Saudi German Hospital in our region is an active participant in providing medical care for our patients in the region and medical education for our undergraduate and postgraduate students. A leader in healthcare, our belief is a leader in interprofessional education. Thank you so much for giving this opportunity, and thank you so much.
Good afternoon. May I invite moderators, Dr. Msha'el Al-Aliani, Dr. Hiba Mityazidi, and Dr. Dr. Dina Barakat. Please come to the stage and moderate the next session, please. Dr. Hiba.
Good afternoon, everybody. Marhaba. We're going to start our next session. My name is Dina Barakat. My background is in physical therapy and also in public health, in interprofessional collaboration. And next to me is Dr. Hiba. She will be also introducing herself. And then we'll start after that with our first speaker.
I am Dr. Hiba Al-Mityazidi, Assistant Professor of Critical Care and Emergency Nursing, College of Nursing, KKU. I am a member in the scientific committee of this conference.
Okay, we'll start with our first speaker, Professor Zaid Al-Hamdan from Irbid in Jordan. He will be talking to us about the interprofessional collaboration and education and the perception of the clinical learning environment among Jordanian nursing students and instructors.
السلام عليكم. في البداية مرحب فيكم وأحب أشكر اللجنة المنظمة وجامعة الملك خالد على الاستقبال وحسن الضيافة وعلى الجهد المبذول خلال السنتين الماضيات في إعداد المؤتمر وتجهيزه ليبدو على أحسن وأفضل حال. أثناء التحضير للمؤتمر الدكتور محمد رئيس اللجنة العلمية الله يجزاه الخير وجهوده مشكورة طبق الانتربروفيشنال اديوكيشن وطبق الانترناشونال كولابوريشن وكان في ناس انفولد من أكثر من مكان وهذا أعطى بادرة صحية على نجاح المؤتمر وأن المؤتمر والاجتماع العلمي إن شاء الله تعالى راح يظهر وظهر لحد الآن بأحسن وأفضل وقت. أنا زيد الحمدان Professor of Nursing and Health Care Management at Jordan University of Science and Technology, abbreviation JUST. JUST is one of the public university in Jordan. It's located in north of Jordan in Irbid. My talk today, with the collaboration with Dr. Hala Bawadi, will conduct this study about interprofessional collaboration and education, perception of clinical nursing environment among Jordanian nursing student and instructor. Why we choose this topic? As you know, the clinical environment and clinical places, it is a vital role in prepare the nurses and doctors and physiotherapists and dentists, all health occupation, they prepare them very well. In Jordan now, with a dramatically increased number of students and a lot of demand on the clinical setting, our students, mostly they are going to the clinical places and go back without enough training. The best way to decrease demand on the patient and to increase the clinical experience is to implement the collaboration and interprofessional collaboration. In Jordan, actually, we have more than 18 bachelor student program in nursing, and we have 28 nursing master programs, and we have one PhD program, and the next PhD program, inshallah, will start next year, and it will be doctors of nursing practice. Also, we have 8 medical schools, and we have more than 14 pharmacy schools, plus the allied health schools. In 2019, I conducted a study to identify the perceptions of faculty members about the interprofessional education, and we find different point of view. After that, we go to next step we're going to the qualitative study to understand from the perceptions of the clinical teachers who take our students to the clinical places, and to take the perceptions of the student regarding the clinical places and the clinical setting. Since WHO started with patient care, or patient-centered care, it means all of us as a healthcare provider, we should provide the maximum, best, and cost-effective care to our patient. And this, without collaboration, without coordination, we cannot reform this. And actually, from the literature review, the quality of a clinical learning influences student interprofessional attitude, teamwork. And our clinical teacher play as a role model for our student. Our problem in the clinical setting, each profession deals with his identity. I should observe and supervise the medical student. I should observe and supervise the nursing student and the allied health. Until now, we don't have any joint round or any joint lecture or any joint post-training conference to discuss all students from different health professions to sit together and discuss about the patient care. Until now, it is not implemented. And for that, they suggest about strategies to strengthen IDE within nursing education and practice. This is from nursing point of view. In the same times, we move to the other health studies, like example, medicine, pharmacist, dentist, applied health, physical therapy will be the same thing. The role of model of mentoring, they have 3 stages. Stage 1, the mentor take the lead using listening and questioning skills to negotiate an agenda. Stage 2, the mentor support, coach, and offer constructive feedback. And stage 3, action planning, promote creative thinking, helping the mentee with decision making. And if the clinical instructor, he know nothing about the interprofessional education, he know nothing or he not go ahead with interprofessional collaboration, then he will be not ideal role model for his student. For that, we design interpretive phonological study to find out the perceptions and to take full meaning from our participants regarding the research question and their experience in interprofessional education. As you know, in the qualitative studies, we go to the purpose sample. We conducted a focus group interview from 2 public universities, Jordan University of Science and Technology, and from the University of Jordan. And the participation in this study was fully volunteer, and the study passed the ethical approval from the both universities. 4 focus group conducted with the student, 6 to 8 students in each focus group, and this started with the student 2nd year, 3rd year, and 4th year, and 2 focus group with the clinical instructors, each focus group from 6 to 8 participants. In the analysis, we came up with the 4 themes. Theme number 1, attribute of the clinical training placement. All participants complain about the nature of the clinical setting. Now, accreditation body in Jordan, when a new university open, they like to take accreditation for nursing school or a medical school. They ask from them to sign a memo of understanding and collaboration with one hospital. And they accept this. But they not ask number of beds for number of students. Maybe one hospital, he signed this contract with 4 or 5 universities. And by the end, we finished with one bed with 10 students or 12 students on the same day for the training. Nursing students value placement in public hospital where they had opportunities to collaborate and observe interprofessional teamwork while practicing independently. Of course, to practice as a student in public hospital is much better than the private hospital. A student and instructor noted that limited educational resources in some settings, such as the absence of conference rooms, restricted interprofessional discussion, reflection, and debriefing opportunities. Our hospitals are built to be a service, a place, not an education place. For that, in some hospitals, especially who are the oldest building, we find them there is only patient room without conferences room, without lecturing room, and for this there is an absence for any place or shortage of places for discussion and post-training conference. Role modeling and interprofessional support. Student and instructor viewed qualified nurses are key role model for interprofessional learning because the senior nurses play as a role model in the clinical setting plus to the clinical instructor. Senior nurses reflect a good role model for the nurses in their collaboration and play a role in the interprofessional collaboration. Positive collaboration with other professionals enhance student satisfaction and teamwork, and actually this will improve their skills and knowledge. Supportive nursing student interaction promotes confidence and professional growth. Theme 2, attribute of a clinical instructor. Instructor supervision style strongly shapes student interprofessional learning experience. Students perceive instructor as more focused on evaluation than on fostering collaborative practice. And actually, now when the clinical instructor going to the clinical place, they have evaluation checklist. In this evaluation checklist, just they evaluate the student based on this. And as Dr. Zahir mentioned in the morning, now we should rethink about change of our education. Now, the telephone take the place of the clinical building of the universities. Now, the teacher should go to the student, and any university and any clinical staff can create case discussion or both conference and make it virtually to make interaction because to come over about the shortage of places. And more than one profession can participate in that. Many instructors extended their role by one supervision, supporting teamwork and problem solving in a clinical setting. Theme 3, attribute of the clinical nursing curriculum. A clinical training represents about 50% of the total curriculum hours, offering opportunities of interprofessional learning. In all applied health and in nursing, clinical hours more than, and now by law, more than 50%. If the nurses and the other profession, they not implemented the interprofessional education and learning in the clinical places, whereas there is a best chance, then they will not do it in other places. Instructors noted challenges in balancing theoretical content with interprofessional clinical practice because they are full student in their checklist, and in the checklist until now there's no items regarding the interprofessional collaboration and interprofessional education. Okay. Students observe gaps between classroom learning and real-world teamwork experience in a clinical setting. And I think all of us suffer from this. Theme 4, student attribute. Students found interprofessional collaboration and patient care both physically and emotionally demanding. Some lacked motivation to engage by one technical nursing task. Interest was higher in mastering clinical skill than in developing teamwork and communication competencies. Conclusion: the quality of clinical training strongly influenced learning outcomes and interprofessional readiness. Limited practice opportunities and variable instructor qualification constrain interprofessional learning. Differences in placement quality affected teamwork, exposure, and collaborative skill development. Nursing school should integrate structured interprofessional strategies when planning and evaluating a clinical experience. And I think now medical schools and nursing school, they should start introduce the clinical training interprofessionally through the simulation lab, and to develop simulation lab models, but to be interprofessionally. Integrated IBA competencies, teamwork, communication, and role understanding into all clinical training program. Train clinical instructors to facilitate interprofessional learning and serve as collaborative role model. Promote structured interprofessional activities such as joint case discussion and shared clinical round. Align curricula and clinical placement to reflect real-world teamwork across healthcare discipline. Foster a culture of collaboration by encouraging respect, shared decision-making, and reflective practice. And I think this recommendation, not only for nursing student or nursing curriculum, for all health student and all curriculum between the health colleges. Take-home messages: interprofessional collaboration enhance the quality of clinical learning and patient care. Effective interprofessional education requires supportive instructors, structured opportunities, and aligned curricula. Empowering nursing students through interprofessional learning build a more competent and collaborative future work force. Okay, thank you.
Thank you so much, and for sticking to time, Professor Zaid. We'll keep the questions, we'll have the questions at the end of the session. For now, Dr. Hiba will introduce our next speaker.
Our second eminent speaker, Dr. Hani Al-Nawafli. He is a professor of community health nursing and Secretary General of Jordanian Nursing Council, and he is a former member of Parliament and the Dean of College of Nursing, Al-Hussein University, Amman.
السلام عليكم ورحمة الله وبركاته، وأسعد الله أوقاتكم جميعا، وتحية محبة وتقدير واحترام من الشعب الأردني، من المملكة الأردنية الهاشمية إلى المملكة العربية السعودية الشقيقة، وإلى شعبها العربي الأصيل بقيادة جلالة الملك سلمان وولي عهده الحكيم محمد بن سلمان أطال الله في عمرهم جميعا. الشكر كل الشكر إلى جامعة الملك خالد على هذا الترتيب الرائع وعلى هذه الحفاوة والكرم، الضيافة العربية الأصيلة، وليست بغريبة على أهل السعودية. وأشكر الدكتور محمد النعمي على جهوده وتواصله المستمر، والشكر إلى اللجنة المنظمة على جهودها وعلى هذا الإخراج الرائع. أيضا الشكر إلى الشبكة العربية للتعليم المتداخل اللي لها دور في جمع الأشقاء العرب في مثل هذه المناسبات. فلكم كل التحية والتقدير. أنقلكم الآن إلى الجوردينيان نيرسينج كونسل. سوري أنا حكيت باللغة العربية. إلى الجوردينيان نيرسينج كونسل. The Jordanian Nursing Council, chaired by Her Royal Highness Princess Mona Al Hussein, and Princess Mona Al Hussein also, she is the WHO patron for nurses and midwifery in the Eastern Mediterranean region. I want just to give you a brief about the health sectors and the GNC, so it will give you an overview about what we are going, so it will be easy to introduce interprofessional education in Jordan. So this is the health sectors in Jordan. It's driven by the public health sector and the private health sectors, as well as the other agencies similar to what we have everywhere in Saudi Arabia or in any country across the world. Generally, this is the workforce in Jordan. So the physicians consider 38,336, which represent 32.6 per 10,000. And the registered nurse equaled 32,948, which represent 28.1 per 10,000. This is the GNC building in Amman. The Jordanian Nursing Council established in 2002. And we consider this is a landmark in nursing profession, started from 2002. Why? Because we start a lot of regulations and building the nursing based on the scientific and follow the advanced nursing practice as in the developed countries. The mission and the vision of the council. So the vision is excellency in regulating the nursing midwifery profession in the Hashemite Kingdom of Jordan, and the mission regulating the nursing and midwifery profession and empowering its workers through the development and implementation of nursing legislations and policy, participating leadership and efficient human resource with the aim of improving the health of the community member. So this is the board member. We used to have a picture with Her Royal Highness after the board member in front of the building. So the Jordanian Nursing Council role and responsibilities. We have, through the bylaws and the law, we have certain functions and authority for the council, which represent the regulations. So we regulate a lot of things. For example, the licensure exam, and we conduct the licensure for the whole country for nurses and midwifery. Also the specialization, we are the one responsible for offering the specialization exam, as well as certifying the specialist, and we have two levels of specialization. We have a specialist and we have advanced nurse specialist. Also education, we also interfere in the education, and we develop and we suggest a lot of policies to the Ministry of Higher Education in regard to nursing education as well as nursing practice. Also policy development, professional development, advocacy and research priorities. Therefore, we always, every 5 years, we update the research priority for the nursing profession across the national. Therefore, we develop, the last one was from 22 to 26, the national research priorities. So it's already published online. So the nursing researcher in Jordan could access this database and get benefit if they want to conduct any research in their work or in the future. Why we need interprofessional education? You know, after coronavirus, there's a lot of things has been changed. Therefore, we are forced for movement, for advanced practice, for collaboration. Why? Because we have also aging population, we have epidemic every now and then, and we have mental health also raising, we have maternal problems. Therefore, there is a challenge for the healthcare workers to be collaboration, have more collaboration between health team members, physicians, nurses, pharmacists, all healthcare workers to have an teamwork continually to care in order to have or to reduce the medical error and to have more cultural practice for more safe patient life. Also, the global health policy driven through the international trend. So we look to the WHO work on in terms of the interprofessional practice, interprofessional education. So we get benefit from the WHO framework, which introduced in 2010, as well as the call of the strategy and strengthening the health system from the WHO call, as well. Also, we look to the United Nations Sustainable Development Goals, and it has different articles and different goals, look like the good health and well-being, gender equity, reduce inequalities, and a lot of things. Also, the global strategies on human resource for health workforce 2025, 2030. This is introduced by WHO, which call for transforming health profession, education, and promote collaboration between different health sectors. Also, the International Nursing Council and the Midwifery Council. Also, there's a lot of work has been done by these institutions, enforce nurses and guide nurses to work on the international or to create the intra-professional education. The GNC experience in IBE, there's a lot of things we believe, not only we believe, we are practicing day to day as interprofessional practice, which is education, which is look like the licensure exam, specialization, international collaboration, and simulation and training, accreditation of CPD and examination. So for example, the licensure exam, as by laws, we are responsible for preparing and conducting the exam, and really it's a real experience of IBE. How? We have 7 expert committees from different fields. They are sitting and putting the exam. So this is the first one. Second, a national nursing competencies. We build our exam based on national competencies. So the national competencies has been discussed by universities, discussed by those who are working in the clinical site. We get their feedback because they are the stakeholders. They are the one who will take the end product of the universities. So we want their opinion. The interprofessional collaboration. How? Once we are planning to conduct the exam, we communicate with the university, because the exam will be held at the university. So there will be a collaboration between the Jordanian Nursing Council staff, the university staff, and the university staff consists of IT people, administration, and nursing staff from the GNC. Also, the committees, the exam committee, also they are witness and chairing the invigilation of the exam. So there's multi-sectors participate on the exam procedure. So it's a real exam of IBE. The specialization. Specialization is another issue, and we believe that the specialization, it's the vehicle and the elevator for the nursing profession in the future. And all the world are going toward specialization. So, through standards and competencies framework, curriculum design and clinical training, also through continuous professional development. This is a real example. We are doing it on a day-to-day basis. The partnership, the international partnership, we have a great collaboration with the WHO, and we have a real experience with the WHO. We got some project to train and to upscale and the nurses in Jordan, and to create, we create diploma in mental health, we create diploma in primary health care and integrating mental health in primary health care, which we call it MHGAP. Also we have with the UNORWA, we have also another success story with the UNORWA. So we conduct a diploma and a professional training to the nurses and the physician and the healthcare workers in the UNORWA centers in 5 regions, in 5 areas, in Palestine, in Jordan, in Syria, and Lebanon. And this was through Zoom and through our platform. We have a training platform, electronic training platform through that. So we use also the digital transformation and the digital media. Also with the Romanian partner, we have also a success story with the Romanian partner, and we used to send for them nurses and physicians as well from Jordan to have exposures to the emergency service in Romania for 1 month. And the group consists of nurses and physicians. So also this is another type of intra-professional education. Other partnership with ICN, International Nursing Council, and Pearson View, and also with Cleveland Clinic, and with the Arab Board of Specialization. What we get benefit from that? We enrich our curriculum. We develop our curriculum based on our exposure to the international experience. Also, we trained, we got another method. Once we send our nurses to Romania, when they came back, we enforced them, we asked them to do a training program as TOT to their staff in Jordan. So they should bring the experience and try to help their colleagues in what they gain experience. Also global experience and standard issues assessment system. This is some pictures, real pictures about what we are doing at the Jordanian Nursing Council. Also, we have also a key role in performing OSCE exam. We have a simulation center, well-advanced center in Jordan, and we have 6 OSCE rooms, standardized OSCE rooms. So we provide the service of OSCE rooms skills and experience to the Jordanian Medical Board. They do some of their OSCE exam for the Medical Board, Jordan Medical Board, as well as the Arab Board. They do also some of their exam for the OSCE in Jordan. Also the simulation, as you see also the simulation, we had a lot of experience and we train nurses and we train other healthcare workers in our simulations in order to have a culture of simulation education and simulation expert in the country. Since simulation is a new era in the health world. Also the CPD, we are responsible and doing some kind of professional education to the nurses, and we conduct in the CPD, especially we are registered or accredited by AHA, so we do basic life support for nurses, for physicians, for other health workers at the same time. So this is also another story of interprofessional collaboration. Also, this is another picture, shows our experience. Accreditations, also we do the accreditation. Person view, we have Center for Person View, so we used to conduct all the exam of person view. So we got nurses, we got physician, we got accountant, we got different people that used to come and have their exam in the center. Call for action. What we need? Great conference, great presentation, but we need to focus our vision, our plan on curriculum and training. We need all of us, when we go home, to have focus on developing our curriculum and focus on training. We don't need a theory-based interprofessional education. We need, the most important is to have interprofessional education focus on the clinical area. Also, we need a faculty and capacity development for the staff. This is very important to create this culture among university and among all this, so it will institutionalize. It's very important to have institutionalize the interprofessional education on our institution. Finally, integrate the interprofessional education across education, practice, and regulation. Regulation is the most important issue because it's the roadmap. It will open you the formal channel of the interprofessional education, and that's all. Thank you for listening, and I'm sorry if I get delayed. Thank you.
Thank you so much, Dr. Hani, for this directed presentation.
Our next speaker is Professor Salman Guraya. He is a chairman, Interprofessional Education and Practice Committee, Professor of Surgery, Lead Medical Education and Clinical Training, Simulation and Assessment at the College of Medicine, Department of Surgery, University of Sharjah, UAE.
Thank you so much. It's really a pleasure to stand before this audience, and I really appreciate the efforts for arranging this prestigious event. And it is wonderful to have you here. And what I want to see that interprofessional education and practice is not a new event. It's not a new concept. Most likely, it was introduced more than 4 decades, and it is still evolving. It is still being considered. We are still planning to integrate in medical education and so forth. But I have seen that being a surgeon, being a colorectal and surgical oncologist and a medical educator, there are certain gaps, there are certain caveats which we are not able to overcome so far. And probably this is the thing that we are meeting again today, that let's look into the problems and then how to solve these problems. Okay, I have prepared this presentation through a lens of a surgeon, And I have shared certain experiences, accomplishments, and at the same time certain roles that I have been performing over the last 1.5 decade in the region and globally. And I hope we will be able to understand what exactly is going wrong and where is the problem. I will start with this notion. You can see now as a senior medical educator, as an administrator, and leading so many committees and institutions, I can see that the problems that are brought to my table, most of them have been solved yesterday, but now they are coming with a different perspective, maybe through different scale or intensity or urgency. But then looking into those problems, we come to know that they were solved amicably, question marks amicably, but then later on they are coming back again. There must be multiple reasons across healthcare systems and institutions, but I can see that one of the reasons is micromanagement, delegation failure, and one-man show, that we think that I can do every single thing, I am a perfectionist, and I don't need a teamwork. So when there is no teamwork, we are all, none of us are angels, and then we come across problems. So I will be talking about this. So some of the things that I will be sharing now, as I said, that they are my practice-based experience, using collaborative practice and using different teams in different institutions, nationally as well as globally. As a surgeon, I will start with this example. How to go back? Okay. You can see here, this is just a surgeon's perspective. I started, when we removed thyroids, we used to cut in front of the neck, and this is a problem of young ladies, and scar is always a problem. So I introduced transoral thyroidectomy in Emirates along with my colleagues. And then what we did was that you can see on the left bottom picture, the 3 laparoscopic trocars were introduced through the mouth, and then on the top there was an endotracheal tube by the anesthetist, and these 4 trocars are introduced, and then we are taking out the thyroid through a scarless surgery without putting a single needle or scar in the neck. So it is really a big creative surgical innovation. We have published our reports. I started with publication of a case report, followed by a series, and now we have done more than 200 transoral thyroidectomies. This was not an easy journey. It took me ages. So one of the reasons was that, to develop like-minded people team. So my team included anesthetists, because now I was standing on the head end of the patient, where always you will find the anesthetist. So I had to argue with them, I have to convince them that you put the endotracheal tube in and later on I will take care. Then came the nursing, then came the physiotherapist, then came my assistants, because the limited vision was there. It is really innovative thing, but there was a big change. So how did I succeed? You can see here, the first and the foremost is the attitude change. We must change your attitude. When we are talking about collaborative practice in healthcare systems, we are not leading the team, we are team leaders. Sometimes in the operating room, I was working as a team leader, but the moment the operation was over, my surgical nurse used to take over. So roles and responsibility would change dramatically in healthcare, but we should change our attitude that we should work together. Surgeons cannot work together alone unless they are working in team. Then you can see that team working is always in place. Role recognition. Again, all healthcare professionals working in collaborative practice, they have their own defined, discrete roles. And we should know what is my strength, what is my boundary, and how to lean forward or lean on other colleagues. So if we have the attitude change, of course, the things will be very easy for me. Now, why patient safety matters, my today's talk. You can see that about 1 in 10 patients. It's a global, it is cited, it is an honest figure. 1 in 10 patients who are being managed in healthcare systems, they are harmed, whether by harmful events, avoidable events, or maybe preventable events. Similarly, the financial cost is more than 17 billion annually. It's only in USA. The most common error, what we say, which are threats to the patient safety, are medication error. I don't know, there are pharmacists here, they can challenge, but this is again an honest figure. And whether they were wrong medication, there were medication reactions, overdose, missed dose, a combination. And lastly, you can see unsafe surgical practice as well. Certain errors are avoidable and certain are not. And then we have developed surgical checklists, we have developed certain roles and responsibilities, policies and procedures, but still it carries on. One of the things which is, you can easily Google this slide, this image, a scissors was left in the chest after a long esophageal surgery. And there was, it was in the UK, it was reported, GMC investigated, and of course with a very bad outcome. But then it is recent, what happens? All barriers were certainly broken down. There was a communication barrier. It led to retention or forgotten instrument. There are so many other incidents. So this is one of the things that we have to highlight, how and why patient safety is so critical and how collaborative practice can minimize, if not mitigate. Now you can see what are the preventable errors. Preventable errors, on the top is fragmented care. We work in silos. We have been listening since morning. One of the reasons for working in silos is that because you have been trained and educated in silos, in fragmented boxes, black boxes. And we were never educated and trained to work cohesively as teamwork. So of course, when we go for clinical practice, we continue the same. So this is one of the reasons. Then procedural errors I mentioned. Hierarchy, it is always a bureaucratic inertia that myself also is a part of this problem. But then if I say something, I expect that the same order will be trickled down till it's effective. So where is the team working, where the shared decision making, it is not happening. So probably this is one of the things that we have to look into. Structured team brief is not there, handover gap, time pressure. So we are working in pressurized circumstances, especially in surgical and its health specialties, where we have less time to think, to ponder, and to maybe to reflect. If we have time, probably we can minimize certain things. So global and regional patient safety initiatives, including our input, my team input, I will just share with you. You can see we have seen before as well. WHO is a lead organization, and I am proud of working as in the advisory board of the WHO Academy for Lifelong Learning. That's the last one. But here you can see in the first one, they have listened to patients' perspective, which is very crucial, that what went wrong, they are our students, they are a part of the team. If I say that they are not part of my team, probably we will miss a lot. So patient perspective are always included in all these WHO perspectives. Last one again, WHO Academy. Here we are working on developing a high state-of-the-art cutting-edge technology simulation center in Lyon, France. At the same time, we are working on interdisciplinary work. How can we improve the collaborative practice and interprofessional education across the globe? We have been able to develop our own Emirates meds as well. It's like it's second year now. And you can see here, it is no different from IMC, GMC, ACGME, CAN meds, all are very similar. Saudi meds is also very similar. But what we can emphasize here, you can see here, most of the core competencies from an undergraduate and graduate medical health professional should know much about collaborative practice, healthcare systems, the scholarship and all those domains which directly target patient safety. My role have been instrumental in improving the awareness, feasibility, and readiness of interprofessional education at undergraduate level, as well as for collaborative practice in the graduate level, in the residency programs and beyond. I am very proud to share that I developed 3 special collections. One on the top is the Journal of Taiba University Medical Sciences. I am the founding editor of that journal, and I started in Medina Munawwara under Taiba University, and now it is a giant multidisciplinary medical journal in Medina Munawwara, and I am sure in the world, in the region as well. So there I had one interprofessional collaboration practice. The second one on the left side is with the Springer Nature. I am a senior editorial board member of BMC Medical Education. So there we developed a special collection, very popular, and we were able to publish a lot of quality research about from review articles, original research, empirical research, and with some great frameworks. And lastly, here is the simulation and e-learning. It just concluded. It got more than 250 submissions, and now we are in the process of publishing these papers. Again, working with the CAPE, the president, Professor Hubar, we just lost him, and I have been working with him for more than 10 years. So the first publication that I will always share with him is the second one. I did systematic review and meta-analysis with him about IPE and what exactly is the notion, what exactly is the awareness. Then these 3 were from my University of Sharjah. We did surveys, we did interactive workshops and seminars globally as well as regionally, and we reported. We reported heavily that there is feasibility, there is awareness, we want to do that, but suddenly we cannot do that. This one is the relevant to my talk today, that we did the qualitative thematic analysis, which was published in BMC Medical Education, and we used senior medical students. We developed certain structured questions, and then we asked them, and we developed 5 main themes. First one is information sharing and grounding. Again, it comes back from collaborative practice and IPE. Second one was communication. I think the beating heart of all collaborative practice is communication. Then came the professional activities, professional cognitive abilities. If I don't know the theory, how can I translate it to practice? Again, so this was our main theme, that we should be able to translate cognitive abilities to metacognition and as well as to then later on to collaborative practice. Then the negotiating identities, as I told you, role negotiation, professional identity formation, what is my role in this team, and who is the next one who is going to carry on the same responsibility. Again, this is one of our flagship research which was published this year about the development of a leadership program, framework of leadership in academic medicine. Again, a very nice thematic analysis. You can see on the left the codes, the subjectives, and the themes. And we were able to generate 6 themes. You can see 6 E's. So it counted for ethics, education and training, and vision, encouragement, empowerment, and empowerment. So this one you can see, these are all Google. If you Google, you can find all these publications. And encouragement. Out of these 6, you can see engagement, empowerment, and encouragement. Again, these 3 are fundamental pillars of collaborative practice as well as interprofessional education. So it again directed towards the same idea that we should start with the interprofessional education and then expect something in the collaborative practice. How to optimize now? Just last thing. You can see shared goals, shared vision, but common goals. Everybody in my team should know what is my target, what is my short-term, mid-term, and long-term vision. If we don't know that, if there is fuzziness, all the way that What exactly is going to happen, only leader knows, and he's just dictating the roles and responsibilities. This will not work. Again, there will be problems. Effective communication, mutual trust, joint decision making. Again, it comes with synchronous as well as asynchronous communication. And lastly, attitudes. We are very rigid. We are resistant to a change, but we must develop certain skills, how to listen and how to take perspectives. So this is my vision about collaborative practice. You can see here on the top is my goal, and these are my building blocks, which are, again, you might be now a bit worried why I'm emphasizing on attitude, because if we don't change our perspectives, probably this will be very hard to move forward. So let's see our research, all this work brought the first one, leadership. I have alluded already leadership. So leadership has so many interconnected, nested values with attitude, role recognition, teamwork, respect and trust. So almost all these traits that I have alluded. Professionalism, again, the top one, competency in professionalism, in communication, collaboration, interactivity, engagement, respect and trust. And lastly, you can see practice-based learning. After I became a consultant colorectal surgeon, I should not stop thinking. So I should always improve through my CPDs, through presenting in conferences, by doing research. So again, you can see all of these have very strong intertwined relationships. So they cannot be taught or educated as a single domain. They should be very nicely coherently educated and trained. So you can see complex medical education system. There is no doubt about that. It is always evolving. It is a moving target. Then comes the competency-based education. Unless we bring interprofessional education and collaboration as a core competency, we will never win. Because then the foundation does not have IPEC, and suddenly we say these doctors don't follow collaborative practice. They can't. They are not tuned. They have not been rhymed on this practice. And then the competent graduates will come who are fit to practice if we follow this pathway. And of course, professionalism remains fundamental. This will lead to collaborative practice. Teamwork will be there. And patient should be a team member. She should be a part of the healthcare system. He is a partner in collaborative practice. Once we do it, you can see safe patients. All these parameters, all these pathways should be followed before we talk about, before we expect safe, secure, and happy patient. These are the references that I used for my presentation, and thank you very much.
Thank you, Professor Salman. If you would like to join us for the question, Professor Hani and also Professor Zaid. Anyone has question? We need a microphone, I think.
Assalamu alaikum wa rahmatullah. Thank you for this enlightening session. My question to Prof. Ziad or Zaid, because at the beginning you talk about the arena of healthcare perspectives and the number of medical schools and etc., and the complexity of bringing them together. But I think there is also another hindering point, which is the context of the profession in the future. I'm talking about the Saudi system. It's doctor dominant, where we really doesn't understand the essence of the role of the other profession. And usually this is kept under the surface because of either the regulation or the privilege given to the profession. How can we link the growth throughout the undergrad to the postgrad till the professional life to create the real integration between the different professions.
Okay, thank you. Okay. Actually, we talk about interprofession, and sometimes we need to talk about interprofession. Even within the profession itself, they have one specialty domain and the other. And now, I think in the interprofession, first of all, we should respect the other profession. From here, if we deal with respect for the others, we work as the team. Here, we keep the professional identity, and we work as a team. In the professional identity, I do my role. In this case, without exceed my border, I respect the other role, and all of us, we share, we have a sharing decision about the patient. If we go through this respect and don't exceed your border, don't think yourself, I am the dominant. As in Saudi Arabia, it is in Jordan, and I think everywhere, it is physician dominant, the healthcare system. Even like example now in Jordan for the healthcare system, in the law, the director of the hospital should be physician. Why? We fight a lot to change for the healthcare center, and they change physicians or dentists. And now we fight to make it open. Physician, dentist, nurse, pharmacist, and there's a good experience in Oman. The director of the healthcare center, some healthcare center is nurses. Because in the doctors, as we know, to work in the health center, it's a transition period until you secure a place for specialty, you moved. Now, if we respect the identity, our professional identity, and we work as respect the other profession, and here we work as equal member in the team to find the best solution for this patient and to work for the sake of the best for our people and to work as patient care. So I think if I, as a physician, work with the nurses directly, it's not mean it's a downsizing of my role. No, but we go to the floor to the patient, we share all the decision. I respect my identity, professional identity, and other people, they respect their professional identity. I don't know if I answer you or no.
Can I add something from my experience? I think we need to have a bylaws, interprofessional educations bylaw, which will regulate the relations between professions, and the committee will put the bylaws will be sharing from all discipline, and they will agree on the bylaws, and this is the roadmap. Because bylaws will regulate. Without having a bylaws and regulation, the things will be mixed and upside down. And finally, it will be those for the strongest or the power. Those who own the power will get what they want. But if there is a bylaw, will regulate the relationship.
I want to add one point also. Now, like example in Jordan, to renew the certificate, we need to complete at least 30 credit hour, 30 CMD. I think now by law, they can make, like example, 8 or 10 hours. This should be in the interprofessional education, interprofessional collaboration, or share conference, share post clinical conference, to encourage our people to attend and to work collaboratively.
We do have a question here, please.
Assalamu alaikum. I think I have a feeling of guilt that I'm going to speak in Arabic. I need to apologize for our colleagues who are not Arabic speakers. But my point of view that most of the audience, most of them are not capable to discuss in the English language. So we deprive them from the possibility of participation in discussions. Why? So I would apologize, but I will speak in Arabic. if you allow me. Now, الحقيقة أنا كنت أتوقع workshop يعني ورشة عمل مختلفة عن المحاضرات. أنا استمتعت كثير جدا بالمحاضرات واستفدت منها، بس في ذهني ورشة العمل مختلفة، فيها نقاش، فيها حوار من الجميع إذا أمكن. هذه النقطة الأولى. النقطة الثانية أحب أنبه إلى مشكلة خطيرة في بلادنا العربية وفي غيرها. احنا شفنا أرقام في الأردن في 36 طبيب لكل 10,000 و32 ممرضة كل 10,000. إذن أمامنا هرم معكوس في كثير من الأمم الغربية. وصلوا إلى 3+4 ممرضات لكل طبيب. هذا ما يجب أن يكون، والمشكلة بتزداد خطورة. بس حبيت أنبه لها، وأنا أعتقد أنه التعليم التداخلي أو المشترك أو البيني ممكن يسهم في علاج لو أحسننا الاستفادة منه، بالإضافة إلى التعليم الرقمي. وشكرا لكم.
شكرا. بليز بدنا ناخذ سؤال.
السلام عليكم، مساكم الله بالخير جميعا. راح اتكلم بالعربي عشانك دكتور. طيب، اولا المحاضرات جدا جميله ورائعه، استمتعنا فيها، وعرج على ما قال الدكتور فعلا في انكشاف وظيفي في مهنه التمريض هنا في المملكه. Professor Salman, I would like to thank you for your great presentation. I have one comment about one thing you mentioned, which is the hierarchical communication. I think the answer for this challenge is one word, or two words actually, mentioned by Professor Al-Jindi, which is psychological safety. So if we provide psychological safety to the team members, even where you are in the hierarchy, you can speak up, you can talk, if we provide you the psychological safety. So that I would like to hear your thought on it. My second comments, I would say it in Arabic. حاليا انتم عارفين ثورة AI والAI here to stay. وقبل اسبوع كنت بحديث مع ستارت اب وعندهم فكرة مشروع to predict major health event 3 أيام قبل حدوثها. For example مثل MI قبل حدوثها من 3 أيام with high accuracy rate. حاليا كان ويا انه نفكر انه expand the healthcare team to involve other professions to like inform us, because we are not fully aware of the tech, the programming, the AI. So can we involve them in the IPE? So I want to hear your thought about it. Thank you very much.
Yes, thank you for your comment about hierarchy. Do you know this is a necessary evil? We have to assign a person who should be held accountable for a decision. if there is no decision maker who will never be held account, so how can we move? We cannot move. There's somebody is a final signatory that this is the decision, maybe by a committee, by a college, by an institution, or by a country, and he is the final authority. He is executing it now. Now the process behind this execution, this is a matter of concern. We have a new word that I shared in one of my publications. Instead of hierarchy, I emphasize on flattened hierarchy. Flattened means we are sitting on a table, there is a boss, there is a team, followers, and you know the difference between managers and leaders. I published one paper here from when I was working in Saudi Arabia. Its title is Managers Generate Followers, Leaders Generate Leaders. So managers means I come here, I have a checklist. I have 20 jobs to be done today. So I tick box at 5 p.m. all job done. Very good manager. So this manager can continue for decades. But what is the difference between manager and leader? This manager does not have a vision. He comes with a checklist. He works, established, accomplished, goes home. A leader will come. He will say, "You are doing this every day. What is your creativity here?" There is no creativity. So creativity means if you have invested on expansion of the organization, critical mass development. Let's say we always talk about the development of critical mass in IPE. We are still struggling. We don't have a critical mass that can work, expand, or that can embed or integrate the IP in the curriculum. Coming back to the same thing again, I would say that the trust, the respect, and the communication, these are really the buzzwords. When we sit down together, we must listen to each other, and with respect and authority, I will take the responsibility. So there is a bureaucratic approach and there is a flattened hierarchy approach. If we are adapting a flattened hierarchy approach, things will be very easy, a person will still be held responsible, and things will move more professionally.
Second part of your question, also I will answer in Arabic. It's the time to involve the other people from other discipline. Yes, we have a cross-discipline interprofession. Like example, from engineering, من الهندسة, we have in the international group, the global one, عندنا ناس health economics, عندنا ناس public administrator, عندنا economics, عندنا مهندسين. يعني المهندس المعماري اللي بده ياخذ ديزاين للاي سي يو، المهندس اللي بده ياخذ ديزاين للليبر روم، هم برضه جزء من التيم تاعنا بكون. والسايكولوجيست اللي بيداوم عشان برضه to provide psychological safety for the staff. الإدارة والليدرشيب والمانجر لازم ما يطلع بس على المريض، يطلع برضه على الطاقم الصحي الموجود. لأنه إذا كان عندي طاقم سليم راح يؤدي شغل، يعمل شغل كويس. أنا هدفي الأخير مش بس بروفيت، أو هدفي إنه المريض not complain or كمان الستاف not complain and to make retention. وطفتك حكيت عن الهرم معكوس بالأردن. إحنا عندنا مرض اسمه حرف الدال، إنه الكل بيسعى إنه ابنه يدرس طب ولا يدرس تمريض مثلا عشان يزيد حرف الدال. بس أتوقع من 2-3 عندنا الإقبال على التمريض في الأردن. لما السنة هي على سبيل المثال معدل قبول التمريض بالجامعات الحكومية 92 والهندسة 82، يعني صار الإقبال على التمريض هو السكند شويس. فهذا بيؤدي بالإضافة إنه صار عندنا صب سبيشالي للتمريض، وصار عندنا توسع أفقي وتوسع عمودي للتمريض. هذا زاد الإقبال على التمريض بشكل عام.
Thank you, Doctor. And just for the sake of time, we have started 5 minutes مأخرين, so we'll just take one last question. And to answer your question about the IPE and AI, yes, we have discussed this yesterday, and definitely it has to be implemented. It is not just to stay, but to progress. تفضل حناخد آخر سؤال. I would apologize من أي حدا who needed to ask a question. We passed the time. Our speakers were going to be with us today and tomorrow, so please feel free to talk to them and to socialize during these 2 days.
شكرا جزيلا لجميع المحاضرين. سأتحدث بالعربي ولا بأس يمكن يعني بريف الدكتور سلمان بريفلي إذا لم يعرف يفهم السؤال بالعربي، وإن كنت أتوقع وقد عمل في المملكة وعمل في الإمارات أنه في الوقت الحاضر يستطيع فهم اللغة العربية. هل ذلك صحيح؟
I just heard my name. Apart from that, I did not understand anything. From there, I can assume this is for me, but I don't know.
I'll brief you later on. طيب. سؤالي الحقيقة أرى كثيرا ما نتحدث عن التعليم المتداخل، ونركز كثيرا على الأندر جراديويت، على التعليم في المراحل قبل التخرج. لكن كما نعلم أن الطالب يتعلم أكثر من القدوات. هل نحن نعطي نفس الأهمية للعمل في تحسين صورة العمل المتداخل لنصنع النموذج في المستشفيات يراها المتدربون سواء في البوست جراديويت أو في الأندر جراديويت فتسهل العملية بشكل أكثر، أم أن الانفسيس الأكثر على الأندر جراديويت؟ My question, Dr. Salman, is that we need to enhance the interprofessional collaboration and practice in the hospital, which is the key for the undergraduate to really see the role model of all the professions. How do they practice together and work as one team? And I'm not seeing the same emphasis to correct the problems which are currently happening in the workplace, but rather talking more about undergraduate. So this is the briefing. And I was saying, by the way, I expected Dr. Salman at least to understand Arabic if he's unable to speak Arabic, since he has stayed long years in the KSA as well as Emirat.
I can't agree more. Inshallah, this is my wish list on my table now, to be proficient in Arabic, and inshallah I will do that. And you will be the first one. I will share my certificate with you. About the collaborative practice, same thing, you know, if I was not trained collaboratively, undergraduate, during my surgical training in England, once I become consultant, I have developed very bad habits, and it's too late. Even I am a surgeon, I cannot surgically dissect and remove my habits. These are now imprinted. To some extent we can win, but you know, the way collaborative practice means, what is the real gist of working together, that can never happen. Only thing, as we speak now, as I started with, more than 4 decades of this concept, and this is still unfortunately a concept. We don't have one single structured IPE curriculum in the world as we speak. There are frameworks, there are visions, there are some ideas down in the road, you do this, there are certain frameworks. But if I want to just copy and paste the same curriculum in my university, there is not much information. So we are still working on the development of a gold standard curriculum. But you are right, the leaders should come sit down to make interdisciplinary teams, simulation, the state-of-the-art simulation, they are the best answer. What I have done with working with the Royal College of Surgeons, we have developed interdisciplinary, advanced and intermediate surgical courses, where we bring physiotherapists, anesthetists, surgeons,
primary care holder, emergency medical technicians, they work together. And it's a wonderful atmosphere. Always the feedback is 7 stars. But when they go back, they are lost. So this is the disconnect we should look into and try to fill the gap.
Thank you so much. From my point of view, I think that we should promote the culture of interprofessional education and collaborative practice among students and healthcare providers to apply it 100% inshallah in the future. I'd like to thank Dr. Salman, Dr. Zaid, and Dr. Hani for this eminent session. Thank you so much.
Thank you, everybody. I don't know if it's a typo mistake. It's staying until 3:50, but I assume we have to go to the next session with Dr. Susan. Thank you, everybody, and sorry if we didn't answer all the questions.
Assalamu alaikum. Good afternoon. We have now a session made by our students. It's an ethics scenario that will be projected as a video. And after that, the students will make questions for you as audience, and you can answer. And then we conclude. The moderator of this session will be Dr. Barbara Maxwell on behalf of Dr. Susan Waller, because she is not feeling well. Okay? Thank you so much. So can we start the video, please?
Present me the case. Mr. Ali Misfir, an 82-year-old widow, admitted to the hospital after a fall at home. He has a history of hypertension, type 2 diabetes. Mr. Ali's fall resulted in a fractured hip. He underwent a successful surgical repair, open reduction, and internal fixation 2 days ago.
Okay, increase morphine dose on the PCA pump so we can control the pain. So physiotherapist can come and get him out of bed early. Okay. No discharge today, okay?
Okay.
السلام عليكم.
وعليكم السلام.
استشاري يقول طفي المورفين بسرير غدا ثلاثة.
سنة سبي؟
إيه.
بس المرة اللي فاتت أنا عبارة عن مورفين.
لا ما عليك، خوش ظرفي.
السلام عليكم. استاذ علي، اسمعني، اليوم عندنا جلسة علاج طبيعي. تقدر تقوم؟ تجينا عنده ناقص. جراحين دولي، هذا ثالث مريض يخربون. كل شوي يخدرون واحد زيادة. بكرة بجيكم معدلون وضع قسم الجراحة.
كأن جرعة المريض زايدة. السلام عليكم.
وعليكم السلام ورحمة الله.
دكتور عجلان، مريض غرفة 7 كأن جرعة المورفين عنده عالية والرجال عنده قصور في الكلى. ايش تشوف الطريقة؟
والله ما ادري، الاستشاري قال لنا نرفع الجرعة واحنا سوينا اللي قال الاستشاري.
بالله الاستشاري طلبه يعني. الله يعطيك العافية.
اي والله، الله يعافيك.
تفضل.
السلام عليكم.
السلام ورحمة الله. مساك الله بالخير. سنور شلون؟
حبيبي بغيت أسأل عن إذا نقدر نطلع الوالد اليوم.
مين المريض؟
علي.
علي. والله كيف حالة الوالد؟
هو يعني الحمد لله صار أحسن. إحنا الصدق إننا خايفين عليه، ما نبغى نطلعه، بس إنه حاسس إنه مثقل علينا.
اي عارف. خلاص انا ان شاء الله خلال يومين هذه والله عندي ضغط شويه، احاول اشوف وقت كذا واسوي اجتماع معك ان شاء الله ونشوف حاله الوالد باذن الله.
تمام، بس اهم شيء ما تتاخر لان
لا ان شاء الله، بس عندنا ضغط شوي، تعرف عندنا ضغط شوي، بنحاول نخلص ان شاء الله وباذن الله. امين يا رب. في شيء ثاني يا سيدي؟
شكرا لك.
Okay, I believe the students had some discussion questions that were shared by Dr. Susan. Thank you.
You can scan the code, you will find the questions.
And excuse me, I'm going to use the QR code too because I am a last-minute stand-in. So the first question was, Dr. Safar increases the morphine dose without Mr. Ali's participation in the decision-making. Which ethical principle is most violated under the Saudi guidelines for informed consent? Is it autonomy, respecting the patient's rights to decide, beneficence, promoting the patient's best interest, or fidelity, keeping patient information private? And that question is to our audience, particularly our learners.
So for our first question, 20 participants till now, with the highest answer, autonomy, respecting the patient's right to decide, with the percentage of 75. We also have 24% beneficence, promoting the patient's best interest.
And so autonomy, that engaging the person in their own decision-making is such a crucial part to really person-centered care and to collaborative care. And so it's really nice to see that scoring so highly in this scenario. So, go ahead. Yeah. So before he had the extra dose, did he look like he was fully compos mentis? Not fully compos mentis? He didn't look it to you. What about the others in the audience? How possible do you think it was to exercise his autonomy? Oh.
The doctor didn't had any interaction with the patient. He just came, he just ordered. And I think that's the reason, I don't know the Saudi guidelines, but according to international guidelines, you need to be talking to patient unless he is mentally incapacitated. He was.
Yes. So how would you know that he had the capacity or not?
He should be talking to the patient.
Yeah, interacted with. Where are our students in the audience? Okay, so you've been working on these questions. You had them a little earlier, didn't you? Yeah? So what do you think? It'd be great to hear from you because you've had some more time to think about the scenario. I'll put you on the spot.
So the basic reason why we would argue that it's an ethical break of autonomy is when in the first clip where the doctor came, just checked on the patient and then ordered morphine. He didn't even talk to the patient. He didn't even look at him. Even his son, he didn't even allow him to participate in the decision making.
Yeah, it was, you saw in the video, there was a lot of my back was, the back was to the patient, to the family member, or turned away from the family member. So it could have been that they could have asked, how's your father, how's he doing, what do you think about his abilities right now to make decisions? So there's a lot that could have been done. Okay. So autonomy for this one was the expected answer that does deal with issues of autonomy. And the rationale is, as you've said, that every competent individual should be informed and ask for consent in accordance with society ethical and legal requirements. So consent for treatment is incredibly important. Okay, shall we go on to question number 2?
Using the same code, you will find question number 2.
We'll give you a little time to respond. So for those of you who may not have used the QR code, the question is, Sarah follows the physician's order despite concern for Mr. Ali's safety. Which Saudi ethical duty has she neglected? Is it patient advocacy, acting to prevent harm to patients, accountability, delegating responsibility to the surgeon, or compliance, following orders without objection?
So 23 votes, vast majority for patient advocacy, acting to prevent harm to patient with 70%, and the rest percentages for accountability and compliance.
Okay, so let's hear first of all from our students to see what you think about that as a result. Now we'll give our audience a chance to contribute.
The second question, it is describe what the nurse Sarah started to do. It is follow the advice from the ER resident, the doctor, and it is not away or from the complication of rising this morphine of this patient. This, I think, it's break the ethics by prevent of harm to the patient. From this side, it is the patient advocacy. It is the most correct answer.
Okay, what about our audience? What are you thinking? Are you in agreement? I see heads nodding. An extra comment coming?
Thank you very much. Yes, it's a lesson from the junior and senior. So we are all advocates for patient safety. So whether you are a nurse, you are a social worker, you are a physician, resident, so we should always have the capability to advocate to our patients. Thank you.
Wonderful. And earlier we were talking about, some of the speakers were talking about the importance of psychological safety. And in those moments when you feel that a decision might not be the right decision, working in an environment of psychological safety can really create the setting where it becomes much, much, much easier to step up and say, can I just speak with you about this for a moment? I'm a little concerned. I think there may be a safety issue. And there's techniques like CUS, which is a technique from Team Steps, which teaches you a shared language, where when you use those particular words, everyone in the team is trained in the same language. And when they hear the beginning, I have a concern, it triggers that this is a potential safety issue for a patient. So a really phenomenal interprofessional skill that can help in this setting is from Team Steps, the CUS training, which really gets all the way from I'm concerned to this is a safety issue and we need to stop. And when everyone is trained in that, they can stop in the moment because they all have the same understanding of what that particular term means. And it means we need to stop now and rethink and regroup. So it's a very, very effective interprofessional skill to have in those moments. Okay, question 3 is about Rami notices the signs of morphine over sedation, but only writes a note without informing the nursing staff. Which ethical duty was breached? Is it duty of care, reporting urgent patient changes immediately, collegial respect, avoiding conflict with other professionals, or confidentiality, protecting private medical data?
So with 22 votes, majority of duty of care, reporting urgent patient changes immediately, collegial respect with 9%, confidentiality with 5%.
Okay, so let's hear from our audience first this time, and then we'll ask our learners. So what was your thoughts with knowing that duty of care was our top response there? What made you click for duty of care?
Sorry, I don't want to say what forced me to click first. I'm looking at those who has done the second one, the 9%. It's very interesting. It depends on your personality, because some people are introvert. They don't like to be in conflict. So I have seen in my teams that they are trying to avoid the conflict. So I think we need to be mindful. So I think the lessons for us is that in a team, we need to understand people's personalities. And I think when some people are reluctant to talk, the leader's role is that we need to encourage them to talk.
Yeah, and there's a lot of literature on conflict management, and the fact that we have there's five different conflict management styles that we step into. And we have a tendency to step into one particular style, often a different style when we're in our home lives than when we're in our work lives. But our usual go-to strategies don't work in every context and with every person. So as that leader, I think it's also really important to understand that exact thing, that nature of all of the people that you work with and what their tendency is. Is it to, in conflict, avoid? Is it in conflict to compete? Is it in conflict to collaborate? What is their natural kind of stance when it comes to situations? Or is it that they completely back away and are unable to step into the moment? And so you're absolutely right that those conflict management strategies become really important in the leaders in situations where you do have, you're worried about the care of an individual and the safety of an individual. And just so you know, the students put so much work into designing the video materials, working with the questions. They've done a fantastic job. They're sitting very quietly, but they've done a tremendous amount of work to make this happen. So from the students, did you have another comment about the last question?
From what we see in the scene, the physiotherapist was disturbed by the action of the orthopedic surgeon, but he was not able to be conflicted with him, so he wrote a note and not telling the nursing staff. But he forget his first job. The priority of his job is the duty of care to the patient, and informing if there is any urgent or emergency report regarding the patient. That's it.
Any other students want to make a comment?
We have 2 more questions to go. If you can scan the code, please.
And just to summarize for question 3, Saudi law requires all healthcare professionals to respond promptly to potential harm and to work collaboratively for patient safety. Okay, question 4, for those of you looking at it, for those of you who do not have are not using the QR code, power dynamics and communication. Nurse Sarah fears questioning Dr. Safar's order. What ethical team strategy best helps reduce such hierarchical barriers? Is it structured communication tools such as SBAR? Is it strict adherence to seniority and decision making? Or is it written communication only via supervisors? And thank you to all of you here submitting your answers. It's really helpful. We're watching them roll in.
So the majority for the structured communication tool, SBAR, 80%, strict adherence to seniority in decision making, it's 20%.
Okay, so it would be lovely to hear from the audience which type of tools that you thought might be actually helpful in this structured communication. It'd be great to have some examples and some examples from our learners as well.
In fact, most of the problem that happen to the patient due to lack of communication or poor communication. If the physician or doctor spend more time, listen to the pharmacist when he call him, that this patient with renal impairment and the dose is over, then I think the problem will be sorted. But because of lack of communication or ineffective communication, the problem deteriorates and the patient maybe will die even.
And sadly to say, the literature suggests that around 75% of preventable errors are actually due to poor communication between us and the health professions. And that's quite shocking, really, when you think of it. You know, it's something that we could change by using more effective shared communication tools. And it is a place where interprofessional education really assists, because those interprofessional skills and practice can address those exact communication issues. And we often think that in our own professions we learn a lot about how to communicate effectively, but when we're in the real world, in real situations, we know, because 75% of preventable errors are caused by poor communication, that it's not happening in the way that we would hope. So those shared tools like SBAR, like CUS, those from, as I say, from Team Science, which is a structured approach that gives you lots and lots of tools that you can use, are incredibly powerful because we share them. They're not part of our individual professional training. They're shared across all of our professions, and it makes that communication much easier. Have we a comment from our learners? Oh, sorry, we have another comment from the front.
Yes,
Apologies.
if you allow me. My probably understanding of the question is that none of the above is the answer. I think the best strategy here, the nurse was fearing to mention that there is a problem with the patient to the senior person. And I think what needs to be emphasized as a strategy is the respect between the teams and the shared responsibility about the care of the patient. I think this is what needs to be emphasized to avoid such incident.
And you're just giving a beautiful, beautiful validation for why interprofessional work in the real world of our clinical work matters, because those breakdowns are at the root cause, and at the root cause of that are our behaviors and our trust and our respect for each other. Okay, and so the rationale for the structured communication tools, based upon the Saudi perspective, is that Saudi interprofessional ethics encourage respectful, standardized communication to improve transparency and safety.
For question number 5, it's also the same code. And it's our last question.
And for those not using the code, I'll read it. Systemic accountability and transparency. After the adverse event, which principle should guide the team when discussing the issue with Mr. Ali's daughter? Should it be transparency, open disclosure and acknowledgement of error, loyalty, protecting colleagues' reputations, or efficiency, avoiding delays through minimal reporting?
So for vast majority, about 90% for transparency, open disclosure, and acknowledgement of error.
Okay, so from our audience, transparency. Why did you click on transparency? Thank you.
Well, I think it depends where you work. I mean, I trained in UK. We have a duty of candor. So this is part and parcel of the medical training because you are in a system where the system is protecting you. Because in certain countries, you are reluctant to be open and honest. Reason is that legally, no one is going to protect you. And I don't want to name the countries, but I have seen it. So it means the onus is on the legal system as well as on the organization. If you want to encourage the transparency and openness, then you need to create a culture where people need to come forward without fear or favor.
Thank you. And what about from our learners? What were your thoughts on this question?
Okay, for this question, we are focused to give the patient some importance for the patient, like greeting the patient, looking the patient, feel the patient of the feeling of the patient. It's very important for you don't looking to the patient or tell the patient it have something or something. I think it's the first choice. It is the correct choice because telling the patient the truth, the knowledge of about his condition, it is very important for the medical ethics.
And what about for the family, for Mr. Ali's daughter?
Yes, family is very important, but we break this ethics by this scenario. We don't care about the family of this patient.
So what about for our audience? Any further comments on transparency and family? Thank you.
My question is to you. If he was really your patient, like in real life, would you go and directly tell his daughter that this is what happened? Because first he is not conscious, and then eventually you're gonna have to talk to someone in the family. So you cannot bypass the family, the caregiver or the family member. But in real life, and back to the same comment that was just mentioned, that it depends really on the system. If the system protects you in a way that you will eventually know that you have to be transparent with the patient and with the family, so you'll go and do it. Would you now, if you have a patient, how would you act? Knowing that probably you won't have something legislative to protect you as a physician.
First, we should follow the rule for the country and the government of the health. And the ethics you should follow. For the family, we should have strategy for the family. We go to the father, we go to daughter in the last. But if we miss something, I think we should protect ourselves by insurance.
Yeah, and oh, we have another question in the front.
We know that عامل الناس كما تحب أن يعاملوك. Treat others as you like to be treated. And if you are the relative of that patient, would you be happy if people were not transparent with you or not? هل لو كان هذا أبوك مثلا أو أخوك أو قريبك وحصل له الخطأ هذا، هل ترغب إنه أحد يصارحك ويقول نعم هذا حصل هذا الخطأ وهذا اللي حصل، أم تريد أن يعني أم تكون يعني سعيد أكثر إنه لما ما يعطوك الحقيقة؟ If you just keep this principle, treat others as you like to be treated, I think this is the right way to approach the practice. This is number one. Number two, unlike what other people might think, being transparent with the patient will increase the loyalty and the trust for you. So people may fear of losing the trust when you are transparent and exposing the errors, but this is contrary to the fact.
Thank you. I think one issue also is medication errors. Are they punitive or are they to correct the system? And we were talking here in terms of the cultures, and different cultures look at it differently. I am prescribing that it should be more to really correct the system rather than punitive, but it depends on the system. And unfortunately, some people might elect not to say anything because the system is more punitive.
And that's a really important point when you think about psychological safety, because Amy Edmondson's work on psychological safety is based on the notion that you learn from error, and errors should be something that are opened so that we can actually learn and improve the quality of the care that we deliver. But there's such a culture around errors. Are they hidden? There's regulatory, there's legal issues, there's threats of, whose responsibility is it, particularly in team care. There's a lot of conversations about who has ultimate responsibility if some error happens to a patient. In reality, everyone's responsible for those errors. So there's lots and lots of elements that make errors be hidden rather than errors be disclosed. And so we tend to fail to meet that requirement of psychological safety, that we can learn from errors because of all those system issues that tend to make errors be hidden.
So I think building on what Dr. Nasser said, if you look at the scenario, who is the first victim in medication error? Patient is the first victim. Who is the second victim? It is the healthcare professional who is the second victim. So the brother in the front said rightly, because you need to build that trust. But you suffer as well, because as professional, doesn't matter you're a doctor, nurse, or pharmacist, when you make an error, psychologically you suffer. So you are the second victim. And then we have got the third victim. I mean, these are not my own coined terms. That's the standard way of defining the impact of an error. The first victim, second victim, and third victim. Organization is third victim, or some paper says your family is the third victim. Because when you go back home and take all the stress from your work home, then your family become the third victim. So we need to look at these medication errors or any other error in the system, not looking just from the patient side, but the second victim and the third victim.
I know when something bad happens to patients, that stays with you. That stays with you for a very, very long time, and it does impact the health and well-being of the workforce. It's a really good point.
I look at it from a different perspective, because we should differentiate between mistakes. Errors could happen even with a very excellent institutions, good systems, good physicians, But sometimes neglect also is a big issue. So one size cannot fit all. Some patients you might give certain dose, but those who have comorbidities, elderlies, you have to be very cautious. So I always teach the residents, you have to reset your mind when you approach every single patient, because some patients, they have very complicated medical disease. You should understand them, their conditions, their social backgrounds, their family background before you take any action, whether it's medications or decisions or breaking bad news or whatever. Thank you.
Yes, you're making me think of Sackett, who actually invented and started the work on evidence-based medicine. And we often forget that I don't think he would be very pleased with us sometimes when we talk about what evidence-based medicine is. And we tend to talk about it as it's the best available literature and the best available science. But when Sackett originally described evidence-based medicine, he said that it is the judicious combination, I love that term, the judicious combination of the best available evidence at the time, the expertise of the clinician or clinicians in that, that's my hand, I think, of the clinicians in the moment, but it's also the unique perspective and situation of the individual that is receiving care. So I think what you've just described is the fact that we have often, when we think about best evidence, we leave an evidence-based practice, we leave that piece out. We rely on our expertise and we rely on the best available literature, but it's always tailored to that unique situation for that unique person. And if you combine those three, you get really good evidence-based practice, because it's rare that you actually see a patient who fits the inclusion and exclusion criteria of the studies that are the best evidence. There's always those unique things. That's a really, really important point. So we need to balance all those things together to provide really effective care that is tailored to that individual. So it's a really lovely comment.
We thank Prof. Ali Saeed Al-Qahtani, also Prof. Mohammed Al-Naimi, for empowering us and give us the accessibility and availability to the university hospital, and also for my colleagues starring in the short video for their effort. Sure. Thank you so much.